The committee will come to order. Good afternoon. So before we begin with our markup, I'd like to welcome our newest member to the committee. Representative Brad Wenstrup of Ohio is a decorated war veteran, a small business owner, and a physician. I'm excited to welcome Brad aboard, and we're putting him right to work today as we take action to combat the opioid crisis. Welcome, Representative Wenstrup. Thank you. The opioid crisis has affected every community in America. Today, more than 3 out of 5 drug overdoses involve opioids. We've all experienced firsthand just how devastating these drugs can be for our neighbors and loved ones. This is a tragedy that must be addressed. This afternoon, our committee will consider 4 legislative packages and 3 standalone bills, which are designed to help families and communities overcome the terrible impact of opioid addiction. We'll review each bill in turn in the course of today's markup, but I want to spotlight just a few of the key policies we'll consider. For example, H.R. 5775, the Providing Reliable Options for Patients and Educational Resources Act, sponsored by Representatives Paulson and Kind, among others, looks to improve efforts to educate patients and insurers on the negative effects of opioids and inform patients on possibilities for non-opioid treatments. H.R. 5774, the Combating Opioid Abuse for Care in the Hospitals Act, which is sponsored by Representatives Curbelo and Del Bene, among others, will improve program integrity requirements surrounding the prescribing and health plan communications to assist patients that have been prescribed opioids. This bill will require CMS to develop a toolkit that provides best practices to hospitals across America for reducing opioid use. And H.R. 5788, the Securing International Mail Against Opioids Act of 2018, sponsored by Representatives Bishop and Pascrell. This bill addresses the opioid epidemic by securing international mail, which is all too often an easy route for smuggling dangerous synthetic opioids like fentanyl in the United States. Here, I want to emphasize, as we move forward with this bill today, I am committed to continuing to engage with members of Congress, the Senate, including Senator Portman, and stakeholders to improve it and address valid concerns as we prepare the bill for floor action and beyond. Today is just the first step, but it is a crucial first step. Those are just a few of the literally dozens of noteworthy policies included in the bills before us today. I do want to thank all the members on both sides of the aisle who crafted this legislation. And as I said, our work doesn't end here. We know there's still a long way to go. And I look forward to working together to improve these important proposals as we move them to the House floor and beyond in the weeks ahead. And with that, at this time, I recognize the ranking member for any opening comments he may have. Mr. Neal?
Thank you, Mr. Chairman. I am pleased that you are holding this markup today and that, in fact, it has been carried out in a bipartisan manner. The opioid crisis is not a Democrat or Republican issue. It's a health, safety, family, community, and indeed economic issue. Everyone in this room has a family member or knows someone close to them who is directly now connected to the opioid crisis. In 2016, there were 2,083 confirmed cases of opioid-related overdose deaths in Massachusetts. That's a 26% increase from 2015 and a 54% increase from 2014. In 2017, there was a small decrease, but clearly there is still a strong need to address this devastating trend. Opiate use disorders are rapidly growing amongst Medicare beneficiaries. Medicare Part D spending in opiates far outpaces enrollment, growing 165% from 2006 to 2015. And this map illustrates the highest rate of inpatient admissions related to opioid use in the over 65 population, as you can see on the screens in the room. People think opioid use disorders are a problem impacting only young people, but this chart clearly shows Medicare beneficiaries are also at risk. That's why this legislation that I introduced with Mr. Holding is so critically important. The bill adds opiate treatment programs as a covered benefit under Medicare. Currently, Medicare does not cover this sort of treatment. This would give Medicare beneficiaries access to a range of medication and behavioral treatment options leading to more hope for long-term recovery. Efforts have been made, I think, in many instances to sabotage one of the best substance use and mental health treatment programs, the Affordable Care Act. Thanks to the ACA, millions of previously uninsured adults now have access to health insurance. It guarantees parity and non-discrimination for people who need substance use and mental health treatment. The ACA also expands Medicaid, which is now the biggest payer for substance use disorder treatment. But instead of strengthening and ensuring sustainable efforts in this direction for the future, Republicans have used it to pay for $2.3 trillion in tax cuts. Like I've said before, this is ultimately about affordability. If these critical benefits on which the middle class rely on are taken away, it would be a double whammy. It would not only reverse any progress to curb the opioid crisis, but also increase health care costs and lower coverage and quality. That would be irresponsible. Today's markup covers 4 opiate policy areas: prevention, provider education, beneficiary education, and treatment options. All would make important contributions to the fight. I'm also pleased that we're considering securing the International Mail Against Opiates Act. This legislation stems from the STOP Act, a bill on which I worked closely with Representative Teaberry before his retirement. I commend the work done by the Trade Committee, Ranking Member Pascrell as well on this bill, which enjoys bipartisan support and would help stop the flow of opiates coming into the United States. Although we are taking steps to address opiate use disorders, it's also important to remember that there are many families devastated by addiction and other substance abuses like crack, cocaine, heroin, and alcohol. We should take note of the fact that African American and whites use drugs at similar rates, but the imprisonment rate of African Americans for drug charges is almost 6 times higher than that of whites. Prison is not a suitable treatment program. And the impact of the opioid crisis on labor participation rates across the country should alarm all of us. According to a recent report, the economic burden from opiates was estimated to be $95 billion. Let me take a moment to thank the staff on both sides of the aisle for their weeks of hard work to bring these bills to fruition. This effort exemplifies what has become an all too rare occurrence in Congress: bipartisan cooperation. In particular, thanks to the House Legislative Council, CMS Office of Legislation, the staff of the Congressional Budget Office, and thank you, Chairman, for the time you've invested to get us here today. This is a complicated issue, and one markup is not going to solve this public health epidemic or its impact on society, but it's a darn good first step. Mr. Chairman, I encourage you to continue the discussion so we can directly identify other Medicare policies to further promote access to treatment. Thank you.
Thank you, Mr. Neal. Our first order of business is H.R. 5774, the Combating Opioid Abuse for Care in Hospitals Act. Mr. Cabello is the original sponsor of the bill. We'll recognize him for an opening statement when he arrives. And I will now turn to Ms. Delbeni, original co-sponsor of the bill, for purposes of an opening statement.
Thank you, Mr. Chairman. I also want to thank Ranking Member Neal for holding today's markup to address the devastating opioid crisis. And I want to thank Mr. Cabello for helping to advance the Combating Opioid Abuse for Care in Hospitals Act. It was only earlier this year that the Ways and Means Oversight Committee held the committee's first hearing on the opioid crisis. And I'm glad we're convening today to move legislation that seeks to prevent opioid overuse and improve access to non-opioid alternatives, and thereby minimize the risks of opioid misuse. Just this morning, I met with anesthesiologists from Washington State, and they informed me that approximately 51 million Americans undergo inpatient surgery each year, and over 80% of those patients receive opioids after low-risk surgery. Now, if you think that sounds problematic, you'd be correct, because studies find that an opioid prescription at discharge is an independent risk factor for chronic opioid use. According to the National Institute on Drug Abuse, roughly 10% of patients prescribed opioids for long-term use develop an opioid use disorder. These figures are horrifying and send a clear message that we must improve access to non-opioid pain treatment alternatives. The provisions in this bill will provide Congress and this committee with the answers we need to establish best practices for opioid prescribing and to better align payment policies so that patients can avoid opioids when alternatives are available. I'm pleased to see that this legislation will advance here today, but this committee must revisit this issue to ensure that change is truly made. I yield back.
I'll turn to the sponsor of the bill, Mr. Cabello, to give an opening statement. You recognize Mr. Cabello.
Thank you very much, Chairman Brady, and thank you, Ranking Member Neal, and everyone who worked so hard to bring this package, H.R. 5774, the Combating Opioid Abuse for Care in Hospitals Act of 2018, before the committee today. Tragically, thousands of lives have already been lost to opioid-related drug overdoses. I applaud this committee's extensive efforts to combat this crisis, which has hit my state of Florida particularly hard, and I'm proud that we have been able to come together in such a bipartisan way. H.R. 5774 includes provisions championed by many members on and off this committee, including Representatives Paulson, Davis, Smith, Higgins, and Buchanan. It includes efforts to review quality and efficiency efforts on the treatment of individuals with substance abuse disorders, provide expert recommendations on reducing the use of opioids in the surgical setting, and best practices for pain management, provide guidance on opioid prescribing. It also includes a provision that I introduced with Congresswoman Kuster, H.R. 5699, the Hospital Opioid Solutions Toolkit. The toolkit will contain resources that hospitals can adopt regarding best practices for provider education related to the screening of at-risk individuals and treatment for pain management and non-opioid alternatives, as well as best practices for tracking opioid prescribing trends in hospitals. It will also provide information on effective patient education. The legislation would require that this guidance is developed by the Secretary of Health and Human Services in consultation with relevant stakeholders, including providers and patient advocacy organizations. This is an issue that affects each of our districts, each of our communities. We need solutions that can help prevent opioid abuse, as well as get people on the path to treatment and recovery. Again, I'm grateful for the hard work of my colleagues and the countless hours committee staff has contributed to the effort to combat this terrible crisis. Mr. Chairman, I encourage all the members of this committee to vote in favor of the measure before us, the Combating Opioid Abuse for Care in Hospitals Act. Thank you, and I yield back.
Thank you, Mr. Cabello, for your leadership. Our first order of business, H.R. 5774, the Combating Opioid Abuse for Care in Hospitals Act. We'll now proceed to its consideration. Without objection, the measure will be considered as read and open for amendment at any point. This time I offer an amendment in the nature of substitute, which was distributed in advance, along with the green sheet explaining it. Without objection, the amendment in the nature of substitute shall be considered as read, open for amendment at any point, and considered base text for the purpose of amendment. I'll now turn to Nick Ulecki, professional staff for the Health Subcommittee, to provide the technical description of the amendment in the nature of substitute, with an emphasis on the changes made since introduction. I ask that members hold their questions until after his presentation. Mr. Ulecki, you're recognized.
Thank you, Mr. Chairman and Ranking Member Neal. H.R. 5774, the Combating Opioid Abuse for Care in Hospitals Act, was introduced by Representatives Curbelo, Del Bene, Budd, and Custer. The legislation would expand beneficiary and provider education on the use of opioids across numerous settings in the Medicare program. H.R. 5774 contains a number of provisions that have been introduced previously. H.R. 5699, introduced by Representatives Curbelo and Custer, would require the Centers for Medicare and Medicaid Services, or CMS, to develop a toolkit that provides best practices to hospitals for reducing opioid use, including a template for hospitals to consider adopting as a notice of opioid risk to patients who are prescribed opioids in a hospital setting. H.R. 5779, introduced by Representatives Paulson and Davis of Illinois, would require the Department of Health and Human Services, or HHS, to convene a technical expert panel for reviewing quality measures and gaps related to opioid use disorder in order to determine where opioid-related measures would be helpful to combat this epidemic. The technical expert panel's review will report on the measures within 1 year of its establishment. H.R. 5718, introduced by Representative Smith of Missouri and Representative Higgins, would instruct the Secretary of HHS to convene a technical expert panel to make recommendations on best practices for pain management and reducing opioid use within hospitals and other surgical settings, and analyze post-surgical opioid prescribing and report to Congress on the gaps in that data. H.R. 5777, introduced by Representatives Buchanan and Lamb, would direct the Secretary of HHS to make available on the CMS website recent opioid prescribing guidances applicable to individuals enrolled in the Medicare program and update such guidance regularly. As noted on the green sheet, the Chairman's amendment would make technical corrections to the legislation. Mr. Chairman, that completes my walkthrough, and I'm happy to answer any questions.
Thank you. Are there any questions about the amendment in the nature of substitute? Mr. Doggett, you're recognized.
What does it cost?
We currently do not have estimates from the Congressional Budget Office, but most of those provisions have come out as non-costers or zero effect on the deficit.
Well, if they're non-costive, why are we considering this without knowing that that's the case? Why don't we have a score? Do we have scores on the other bills that we're considering today?
We are currently waiting on final tables, sir.
So we're taking up a series of bills without knowing what they cost, right?
We have a general understanding that most of the bills do not affect the deficit and do not increase spending.
And as far as the provisions that you've just reviewed on this bill, would you indicate what provisions, if the Trump administration thought this was a desirable way to deal with the problem and they considered the opioid abuse issue a true emergency, which provisions could they not implement now without any legislation?
Mr. Doggett, I apologize. I cannot speak to what the administration may or may not do.
Yeah, I'm not asking you to speak about what they may or may not do. I'm asking you, essentially, what is it about this legislation that is necessary for us to act on today? Why cannot the CMS, other agencies, do this without any legislative activity on their own initiative? Is there anything in law that prevents them from acting on this if they think it's desirable and they think that the crisis demands it?
I believe that current guidances lack a good amount of information regarding the opioid crisis and measures to measure whether or not providers in the Medicare program are able to provide such care. And while certain provisions would be required to make statutory changes, there are changes that could be made administratively, but doing so in a statutory manner would streamline the process and increase the speed to which we go after the epidemic through legislation.
Okay, so basically everything in this bill could be done by the Trump administration if they thought it was desirable to do it.
I will have to get back to you on everything.
Okay, well, that is pretty central to the desirability of each of these bills. You refer to guidance. Are you talking about guidance that has been issued by CMS?
Yes, and the Department of Health and Human Services and other subsidiaries other than CMS.
And you're just saying this will give them some direction of the way Congress would like their guidance to go, but if they thought they needed to change their guidance, there's nothing to prevent them doing it, is there?
I believe any administration would have the ability to administer
Right.
a lot of these provisions.
Right. I think any administration would have the ability to administer them, to change them, and to do everything that this bill does. Thank you very much.
Thank you, Mr. You'd like it just to correct, rewind a second. As you know, House rules don't require a score for committee bills moving out of this committee, but before they move to the House floor. But you made a statement here that you don't anticipate, your understanding is that these will not cost, there won't be a financial impact. Is that correct?
We have had conversations with the Congressional Budget Office that suggest that most of the provisions considered today will not have a cost and not add to spending.
Not add to spending, not have a cost. To Mr. Doggett's point, although the Obama administration didn't act to address opioids in this regard either, I think the key point here is that Congress, in a bipartisan way, have developed a series of, we think, important steps to address this crisis through prevention of oversubscribing, education for the patient and the physicians, as well as more access to treatment. This, as you view it, from a technical standpoint, we are exercising as a committee our statutory right by law to direct this administration to take these steps. Is that correct?
Yes, sir.
Thank you. Does anyone else wish to ask questions about the amendment in nature substitute? Does anyone wish to strike the last word?
Mr. Chairman?
Mr. Buchanan, you're recognized.
I'd like to strike the last word. I'd like to thank my friend, Mr. Corbello and Ms. Delbeni for their leadership on this important legislation. The opioid epidemic is devastating families across the country and has quickly become the worst drug crisis our country has ever seen. I can tell you personally, in the communities I represent, Sarasota, Manatee County, it's one of the worst in the state, unfortunately. Today, I want to highlight my bipartisan bill, the Centralized Opioid Guidance Act, which includes, as part of Section 5 of this package, my bill requires CMS to develop an easy-to-use resource guide on its website where doctors, seniors, and others can access all federal opioid prescribing guidelines that apply to Medicare beneficiaries. Since 2016, the federal government has published countless guidelines, reports, and studies on opioids. However, these valuable documents are currently scattered across nearly a dozen different healthcare agency websites and not always easy to find or access. My bill also addresses a key recommendation made by the President's Commission on Opioids, which calls for HHS to coordinate the development of a national curriculum and standards of care for opioid prescribers. The new centralized database will contain current and new guidelines mandated by a comprehensive Addiction and Recovery Act and legislation currently making its way through Congress. Together, these guidelines and best practices will assist doctors and patients making safe, medical appropriate decisions about how to treat pain. Thank you, and I yield back.
Thank you. Does anyone else wish to strike the last word? Are there any amendments to the amendment in the nature of a substitute? Mr. Lewis, for what purpose do you seek recognition?
Mr. Chairman, I move to strike the last word.
Yes, Mr. Lewis, please, you're recognized to strike the last word.
But thank you, Mr. Chairman, again for holding this hearing. We are in the grip of a true public health emergency. Each and every person here knows that we're losing this battle. Every day, nearly 100 people die in this country from this deadly epidemic. No state is immune, and no community is beyond the reach of these powerful drugs. My home state of Georgia has more clinics target this addiction than anywhere in the South. Despite this fight, people of all ages and all backgrounds are dying. Late last year, best friends, two teenagers from Georgia, died on exactly the same day from a drug overdose. Mr. Chairman, stories like these break your heart and show that we need to do more, much more. First and foremost, we need to learn from the lessons of the past, the failed and misguided, quote, end quote, war on drugs. And we should start with the fight and build an evidence-based strategy. We know that addiction is not a crime, it is a difficult and painful disease to treat. A thoughtful response means more than increasing our capacity for treatment. We must also address the infectious disease associated with drug addiction. I believe that we must fully leverage the Ron White HIV/AIDS programs and other federal programs that are in place and equipped to provide highly effective, cost-effective, and compassionate care. Now is the time to learn from past mistakes and to apply all strategies and resources to turn the tide on the devastating impact the epidemic is having on families in our communities throughout our nation. Thank you, Mr. Chairman, and I yield back.
Thank you, Mr. Lewis. And to your point, besides the bipartisan work on these bills, several weeks ago in a bipartisan way, Republicans and Democrats joined together to provide over $4.5 billion to fight the opioid epidemic with access on treatment, prevention, and where appropriate enforcement. That is an area we share as well.
Mr. Chairman.
Thank you, Mr. Lewis.
Mr. Chairman.
Anyone else wish to strike the last word? Mr. Kine?
Mr. Chairman, I move to strike the last word.
Yes, sir, you're recognized.
Mr. Chairman, I certainly don't want to appear to be the skunk at the party here, but no member of Congress is going to stand in front of some pretty benign opioid legislation bills that are moving for Congress at this time, given the scourge that we're all experiencing in each congressional district, in each state, throughout our entire nation. This is an all-hands-on-deck moment. We're going to need strong partnerships at the federal, state, and local level. But in the spirit of friendliness here, I would beseech this committee to get back to regular order and start doing our job. This is a complicated issue. We haven't had one hearing on any one of these bills coming before us today. As I said, reviewing them all, and my name's on one with my good friend Eric Paulson. They are pretty benign. I don't see any downside to what we're doing here today as far as the practical impact that it's going to have. But I think it's important for us not just to show up at the graduation party, but also to do the coursework to get there. And we're not doing that these days in this committee. We've fallen into this trap, whether it's due to political convenience or the timing of the political calendar, of just pushing legislation through this committee without getting a panel of experts and getting feedback and testimony on proposals that we're working on, or looking at the best practices that are being established around the country, or evidence-based research on what is effective or not in dealing with the opioid epidemic. And that's on us. That's part of the responsibility and part of our job description in this committee of Congress. So I would ask, again, as we move forward in future legislation, that we put in the groundwork, that we take the time to study these issues, which we typically can do through the hearing process, rather than just putting names on bills, moving them through swiftly just to meet some type of political calendar around here. I'll have more to say about the particular legislation that I'm directly involved in, but just a friendly reminder that I think we've fallen far astray of what the duties and the responsibilities are of this committee, especially on something so overwhelmingly important as addressing the opioid epidemic in our country today. I yield back.
Thank you, Mr. Khan. I would remind members these bills are a result of multiple hearings we held across multiple subcommittees on this, and one hearing on the STOP Act itself. Does anyone else wish to strike the last word? Are there any amendments to the amendment in the nature of substitute? If there are no amendments, questions on the adoption of the amendment in the nature of substitute, all those in favor signify by saying aye. Aye. Those opposed, no. Being the chair, the ayes have it. The amendment in the nature of substitute is agreed to. I'll now recognize Mr. Riker for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 5774 as amended to the House of Representatives.
Question is on favorably reporting the bill H.R. 5774 as amended. All those in favor signify by saying aye. Aye. Those opposed, no. Opinion of the chair, the ayes have it. The motion is agreed to, and H.R. 5774 as amended is ordered favorably reported to the House. Without objection, I ask the staff be authorized to make technical and conforming changes to the bill. The members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our next order of business, H.R. 5775, the Providing Reliable Options for Patients and Educational Resources Act. I recognize the bill's sponsor, Mr. Paulson, for purposes of an opening statement.
Thank you, Mr. Chairman. Thanks for holding this markup. Members, there's no coincidence that most people are prescribed opioids to manage their pain, even though CMS and the government...
Mr. Paulson, if the gentleman will yield. So votes have been called. I understand they're just a few moments late.
Come back?
At this point, if you would suspend, we will reconvene, suspend the hearing at this point and reconvene immediately after the votes. committee will reconvene. At this time, I will now recognize the bill's sponsor, Mr. Paulson, for purposes of an opening statement again.
Thank you, Mr. Chairman, again for holding the hearing. And as we've seen in the opioid epidemic getting worse and worse, there's an understanding that it's no coincidence that most people who are prescribed opioids to manage their pain, even though the government will also pay for or reimburse for hundreds of medical devices and physical therapy and non-opioid medications, we now know the fact is that many providers and people simply aren't aware about other equally effective therapies. And that's why I want to thank my colleague, Representative Kine, for joining and introducing and authoring the Medicare Choice Act, which is one of the bills in this package now before us, H.R. 5775, the Proper Act. The Choice Act will ensure that Part D drug plans inform seniors about other non-addictive pain management therapies that Medicare covers, so that when they get injured or have some other type of pain, they will be able to ask their doctor the right questions to make sure they receive the most effective and the least harmful pain management therapy. Education for patients and for physicians can absolutely make a difference. Mr. Chairman, I also know that Representatives Black, O'Halloran, and Crowley have put in another initiative as a part of the Proper Act before us now, the package. They will also educate seniors about ways they should safely dispose of unused opioids and how providers should take into account the whole patient when discussing pain. I want to thank them for their important work. And I also want to briefly mention and thank Representative Curbelo for the bill that was included in the last package that I worked on with Representative Davis, promoting quality of care and pain management act that was included. There are many quality measures that have been vetted and approved by a third party that contracts with CMS for that specific purpose. However, we have learned that CMS hasn't actually adopted and put them into place, and that means that providers don't use them when treating opioid users, and CMS can't see which providers use them effectively and which ones can't. And so that bill will fast-track the CMS approval process so they will actually adopt the measures so providers will begin using them during treatment. And I would like to ask unanimous consent, Mr. Chairman, to introduce and submit for the record a letter from Dispose RX in support of the Proper Act.
Thank you. Without objection.
And I will just wrap up by saying this package has strong bipartisan support. I want to thank my colleague, Representative Kine, and others who have been a part of that in helping make a difference in addressing an epidemic that continues, unfortunately, to bring tragedy to too many families. And with that, I yield back.
Thank you, Mr. Paulson. I now recognize the bill's original co-sponsor, Mr. Kine, for purposes of an opening statement.
Thank you, Mr. Chairman. Mr. Chairman, I was happy to sponsor with my good friend, Mr. Paulson from Minnesota, H.R. 5775, providing reliable options for patients and educational resource, or the Proper Act. This bill does combine three different proposals that seek to give Medicare beneficiaries the information that they need to make informed decisions about their medication therapy. First of all, it requires Medicare Advantage or Part D prescription drug plans to provide beneficiaries with information on risks associated with opioid use, as well as alternative or complementary treatment options that are covered under their plan. Some beneficiaries may not be aware of non-opioid approaches to treating pain management, and this legislation will expose them to that. It also includes a proposal based on legislation sponsored by my good friend, Representative Tom O'Halloran from Arizona. It's a bill that would remove pain-related questions from patient satisfaction surveys unless the pain questions take into account whether an individual was informed about the risk associated with the opioid use and informed about the non-opioid alternatives, all of which makes complete sense. Mr. Chairman, I, for the past year, have been traveling around my large rural western Wisconsin, north central Wisconsin district, having listening sessions with law enforcement, with healthcare providers, with treatment centers, counselors, families affected by opioid usage, individuals that have been impacted by it. As a former prosecutor, I used to live in this world of drug prosecutions. I haven't met one law enforcement official in Wisconsin who believes that we can address this through the criminal justice system. This has to be a public health response in order for us to get out ahead of this addiction trend. Otherwise, it's not going to work. We can't build prisons fast enough in order to address it. But there are also some very interesting, neat, innovative approaches being taken throughout the country. And again, I would recommend to the chair that perhaps there'll be some future hearings that we can have, not only tracking the implementation of what we're doing here today, finding out what works or what doesn't, but to study and learn from best practices and what is occurring in both the private and, quite frankly, in the VA Medical Center. I have a VA center in the heart of my congressional district, Toma, that came under investigation a few years ago over overprescribing opioid use. It led to the death of one of our veterans, Jason Simkoski. His family, instead of being bitter, leaned in and working with Congress on recommending changes to the treatment regimen so that no other veteran or no other family would have to go through what they did. And they're emphasizing now alternative, complementary forms of medicine to treat pain, a real innovative practice that I'm hoping, if done right, it could be a model of care not only throughout the VA healthcare system, but throughout the healthcare system of our country. Because I do believe that as a nation, we have done a very bad job of managing pain and put people on this road of addiction and overprescribing of opioid and the vicious cycle that brings. So if these bills, non-controversial in their form, can help move the ball forward in addressing this scourge that all of us are wrestling with in our respective districts, then fine. But let's also, in the future, do a little bit more homework and find out what is in fact working, what isn't, what adjustments that we should be making. Again, partnering at the state and local level, making sure that our local communities have the resources that they have in order to combat this effectively. Because this should be a nonpartisan issue. It's one of those rare issues working its way through Congress today, has an impact on urban and rural districts alike, large districts, small districts. It knows no boundaries. It has no party affiliation. And it is important that we start taking important steps in the right direction. So I encourage my colleagues to vote favorably on this legislation. I yield back. Thank you.
Thank you. And Mr. Kine, I agree. I think future hearings would help us dive even deeper into the solutions, the accountability, the measurement of what we're trying to achieve. So thank you. The committee will now proceed to consideration of H.R. 5775. Without amendment, the measure will be considered as read and open for amendment at any point. This time offers amendment in nature of substitute, which was distributed in advance along with the green sheet explaining it. Without objection, the amendment in the nature of substitute shall be considered as read, open for amendment at any point, and considered base text for purpose of amendment. I'll now turn to Nick Ulecki, professional staff for the Health Subcommittee, to provide the technical description of the amendment in the nature of substitute with an emphasis on the changes made since introduction. I ask that members hold their questions until after his presentation. Mr. Ulecki, you're recognized.
Thank you, Mr. Chairman and Ranking Member Neal. H.R. 5775, the Providing Reliable Options for Patients and Educational Resources Act, was introduced by Representatives Paulson, Kind, Poliquin, and Lamb. In general, this legislation would expand communication regarding opioids between providers and beneficiaries, expand education surrounding non-opioid alternatives, and the risks of opioid overutilization in all settings. H.R. 5775 contains a number of provisions that have been introduced previously. H.R. 5686, introduced by Representatives Paulson and Kind, would require prescription drug programs under Medicare's Part D program to include information on the adverse effects of opioid overutilization and of coverage of non-pharmacological therapies and non-opioid medications or devices used to treat pain. H.R. 5714, introduced by Representatives Black and Crowley, would require Medicare Advantage plans associated with a prescription drug plan to disseminate information to beneficiaries regarding the proper disposal of controlled substances when prescribed. H.R. 5719, introduced by Representatives Black and O'Halloran, would direct the Centers for Medicare and Medicaid Services to either eliminate the 3 pain-related questions from the Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAHPS survey, or incorporate 1 or more additional questions assessing beneficiary education of opioid risks and alternatives in the hospital inpatient setting. As noted on the green sheet, the Chairman's amendment would make technical corrections to the legislation. Mr. Chairman, that completes my walkthrough, and I'm happy to answer any questions.
Thank you. Are there any questions about the amendment in nature substitute? Mr. Doggett.
Is it correct, sir, that the provisions of this bill could be accomplished administratively without its passage? I'm sorry, would you speak up?
Yes, sir.
Could be done if the Trump administration thought this was desirable enough and if they thought the problem was urgent enough, they could have already done it. Okay, could do it without passage of this, right?
Yes, sir. Any administration would be able to do.
Anyone could. It's just that they've been there for a year and a half, I guess, almost. And with reference to the cost, we don't know how much this bill cost either.
Again, we have received feedback from the Congressional Budget Office that these provisions would likely not add to the deficit or add to direct
We
spending.
have no score on it.
We do not have a score yet, sir.
And with reference to hearings on the multiple bills that you mentioned, when were the hearings on those bills?
If I may, Mr. Ulicki, if I recall, not the dates, but I know the subcommittee hearing on healthcare, subcommittee hearing on trade, and subcommittee hearing from oversight.
This bill doesn't have anything to do with trade, does it?
So the combination of the packages that we are addressing today.
Well, I appreciate your
multiple
answering
hearings.
the question, Mr. Chairman, but my question to him was, when was the hearing on this bill? You've told us there have been lots of hearings in response to Mr. Kine, but isn't this a bill that was introduced last week?
Yes, sir, it was introduced last week.
Yes.
The concepts were discussed in nature of all the packages.
Right.
At the
We had
hearing on
concepts
opioids.
discussed of the tax bill, but we never had a hearing on it, and we haven't had a hearing on this bill or the other bills that are up today other than on the STOP Act. Thank you very much.
Thank you, Mr. Ulicki. Is it true the Obama administration took none of these administrative actions during the 8 years that the administration held the White House?
That is correct, sir.
And does this bill reflect multiple members' bipartisan work on addressing a serious opioid crisis with solutions we believe will work? Is that correct?
Yes, sir.
Thank you. Anyone else wish to ask a question about the amendment nature substitute? Does anyone wish to strike the last word? Ms. Black, you're recognized.
Thank you, Mr. Chairman. And as a nurse for more than 45 years now, I've been trained to think about root causes. That was part of our training in how to diagnose a problem and how to build a treatment strategy from the bottom up. And that's the kind of attitude that we need to take to address this opioid epidemic. Everyone in this room either knows someone that has a drug addiction. It does not discriminate. It is affecting the young and the old, the rich and the poor, the rural and the urban. And Tennessee, like many states around the country, is dealing with this epidemic. In 2016 alone, the crisis took over 1,600 Tennesseans' lives. I got into public service because of my healthcare background, and the opioid crisis is a very personal one for me. It's impacting our communities, our friends, our families, and our neighbors. It is both a law enforcement issue and a healthcare issue, so our solution must address both and provide both resources that are needed. The 19 bills incorporated in this markup today are great tools to combat the opioid epidemic, but we must remember that this issue cannot be legislated away. There is no one-size-fits-all solution, but we have a moral imperative to protect our children and our grandchildren. Before we can begin reversing this crisis, we must take steps to educate our communities on the dangers of the addiction, empower our law enforcement officials to shut down and prosecute the pill mills and overprescribing. But most importantly, we must treat those who are addicted to opioids as patients who can recover. I firmly believe that the future generations will look back and judge us on how we handle the opioid crisis, and I would like to thank Chairman Brady and Chairman Roscoe for the work they've done to address this critical issue, and all of the members that consider these various bills today. Thank you, Mr. Chairman, and I yield back.
Thank you, gentlelady yields back. Does anyone else wish to strike the last word? Dr. Davis, you're recognized.
Thank you, Mr. Chairman. In the United States, there are about 43.8 million people who experience mental illness in a given year. In addition, 20.2 million adults had a substance use disorder, of which 50.5% had both the mental and substance use disorder. Representative Paulson and I introduced a bill, H.R. 5779, to create a fast-track process for the National Quality Forum endorsement of new opiate-related performance measures and a pathway for speedy adoption of these measures by CMS value-based program. The bill H.R. 5774, Combating Opiate Abuse for Care in Hospitals, or the COACH Act, introduced by Representative Corbello and Representative Delbene, Representative Budd, and Representative Custer, contains our aforementioned legislative language. We need to ensure that an effective protocol to assess quality measures be implemented in addressing delivery of care, prevention, diagnosis, treatment, and health outcomes with regard to individuals with substance use disorders. I support H.R. 5774 and yield back.
Gentleman yields back. Does anyone else wish to strike the last word? Are there any amendments to the amendment and a substitute? Mr. Dodd, for what purpose does the gentleman seek recognition?
Mr. Chairman, I have an amendment at the desk.
Mr. Reichert, you're recognized.
Mr. Chairman, I make a point of order to the, I reserve a point of order at this time, Mr.
Thank you. Point of order has been reserved. The clerk will distribute the amendment. I ask the gentleman to suspend while the clerk distributes.
It's only a sentence, Kevin. Do you want me to suspend or you want to? Sure. Yeah.
So the gentleman from Texas recognized for 5 minutes on his amendment.
Thank you very much, Mr. Chairman. Mr. Chairman, this amendment does not have a score either, but its purpose is to protect taxpayers and to reduce their expenditures, and it is one sentence. We have substantial evidence, it continues to mount, of the role that pharmaceutical companies and distributors played in over-promoting their products, in minimizing the risk of addiction associated with opioids, and fueling addiction by blocking limitations on prescriber prescription of their products. Recognizing that, states and localities all across our country are seeking redress from manufacturers for their contribution to the epidemic. President Trump's own Commission on Combating Drug Addiction and the Opioid Crisis found that the pharmaceutical industry, quote, embraced and exploited the flawed claims that opioid narcotics are safe to use universally for chronic pain with aggressive marketing and educational outreach. 41 states' attorney generals are now investigating the marketing practices of pharmaceutical companies and their aggressive promotion. Hundreds of cities, counties, and states have brought legal action. Even the Attorney General in Texas this week initiated such litigation. All that this amendment does is to request that the Attorney General of the United States do the same thing with reference to Medicare. We ought not to have taxpayers funding the cost of programs that were the result of someone else's misconduct. There are nearly 90,000 Medicare beneficiaries who are at serious risk of opioid misuse or overdose, and there are approximately 400 Medicare prescribers who've had questionable opioid prescription patterns for those patients that are at most serious risk. Given the substantial role that Medicare and Medicaid play in treating opioid addiction, I think it's imperative that the administration work to recover the significant investment that taxpayers have made to address this crisis. This is a direction to the administration, which the administration could do on its own initiative. It's talked about it. This is simply to encourage the administration to move forward with any criminal or civil action that is necessary to get redress for the taxpayers. It's no surprise that the administration has yet to hold pharma accountable on much of anything. These financial relationships that pharma has developed, both with outside groups and with this administration, have shaped health policy debates in the past. Some 14 groups named in the report that I referred to repeatedly opposed legislative and regulatory measures to establish prescriber limits for opioids are to hold physicians accountable for overprescribing opioids, allowing the opioid epidemic to continue to wreak havoc in communities across the country. Earlier this month, our colleagues on the Energy and Commerce Committee questioned the CEOs of 5 major opioid distributors on their role in the crisis. And in a landmark moment, when asked if his company was responsible for contributing to the epidemic, the CEO of one company said simply, yes. In another watershed moment, the CEO of another apologized for the large, almost unlimited opioid shipments that were flooding into rural communities in West Virginia. So adopting this amendment would simply assure that we send forward a message to the Attorney General and the administration, just as these bills do to other elements of the bureaucracy. Please get about the job of completing your investigation, seek redress for the taxpayers, ask that those who contributed to cause this crisis help pay for the cost that is now being borne solely by the taxpayer, millions, if not billions of dollars that are caused, that will be caused in the future to the Medicare system that ought to be paid for by those who caused it, and I move adoption of the amendment.
Mr. Reichert, you're recognized.
Mr. Chairman, I make a point of order to the amendment because this committee does not have jurisdiction over the provisions in the amendment, and therefore it is not germane under Rule 10. Specifically, this amendment is beyond the jurisdiction of our committee.
So the gentleman raises a point of order in ruling. I am prepared to rule. Mr. Dog, would you like to speak
I would just
on
say
the point of order?
This committee has near exclusive responsibility for the Medicare program. I think we have jurisdiction to encourage recompense for that program and help to preserve its financial solvency. I yield back.
Thank you, Mr. Doggett. So I'm prepared to rule the amendment isn't germane to the amendment, the nature substitute, because the committee does not have jurisdiction over the amendment. It is beyond our jurisdiction.
Mr. Chairman, on that I would respectfully appeal your ruling.
So the gentleman appeals ruling chair, Mr. Reichert. Do you move to table the appeal?
Mr. Chairman, I move to table.
Well, the motion is to table the appeal. All in favor say aye. All opposed, no.
No.
And
Mr. Chairman,
the ayes have it.
Mr. Chairman, on that I would ask for the ayes and nays.
So a roll call is requested. The clerk will call the roll.
Mr. Johnson, Mr. Nunez, Mr. Reichert, aye. Mr. Roscom, aye. Mr. Buchanan, aye. Mr. Smith of Nebraska, Mr. Smith, aye. Ms. Jenkins, aye. Mr. Paulson, aye. Mr. Marchant, Ms. Black, aye. Mr. Reed, Mr. Kelly, aye. Mr. Renacci, Ms. Nome, aye. Mr. Holding, aye. Mr. Smith of Missouri, Mr. Smith, aye. Mr. Rice, aye. Mr. Schweikert, yes. Ms. Walorski, aye. Mr. Curbelo, aye. Mr. Bishop, aye. Mr. LaHood, aye. Dr. Winstrup, aye. Mr. Neal, no. Mr. Levin, no. Mr. Lewis, no. Mr. Doggett, no. Mr. Thompson, no. Mr. Larson, no. Mr. Blumenauer, Mr. Kind, no. Mr. Pascrell, no. Mr. Crowley, Dr. Davis, no. Ms. Sanchez, no. Mr. Higgins, no. Ms. Sewell, no. Ms. Del Bene, no. Ms. Chu,
Ms. Chu, no. Mr. Johnson? Mr. Nunes? Mr. Nunes, aye. Mr. Marchant? Mr. Marchant, aye. Mr. Reed?
Aye.
Mr. Reed, aye. Mr. Renacci? Mr. Renacci, aye. Mr. Blumenauer? Mr. Crowley? Chairman Brady?
Aye.
Chairman Brady, aye. Mr. Chairman?
Clerk will report the vote.
23 yeas, 14 nays.
There being 23 ayes and 14 noes, the appeal of the ruling of the chair is tabled. Are there additional amendments to the amendment in the nature of a substitute? If there are no further amendments, questions on the adoption of the amendment in the nature of substitute, all those in favor signify by saying aye. Aye. Those opposed, no. Being the chair, the ayes have it. The amendment in the nature of substitute is agreed to. I'll now recognize Mr. Reichert for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 5775 as amended to the House of Representatives.
The question is on favorably reporting the bill H.R. 5775 as amended. All those in favor signify by saying aye. Aye. Those opposed, no. Being chair, the ayes have it. The motion is agreed to, and H.R. 5775 as amended is ordered favorably reported to the House. Without objection, I ask the staff be authorized to make technical and conforming changes to the bill. The members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our next order of business is H.R. 5776, the Medicare and Opioid Safe Treatment Act. I'll now turn to Mr. Holding to give an opening statement.
Thank you, Mr. Chairman. You know, we're all too familiar with the devastating effects the opioid epidemic is having on our country. Tens of thousands of lives lost each year, untold burdens on our healthcare system, and billions of dollars in lost economic potential. This epidemic has pervaded all populations, including our seniors. Medicare beneficiaries have among the highest and fastest growing rate of opioid use, yet they do not currently have coverage for the most effective treatment. The MOST Act, which my friend, the ranking member, Mr. Neal, and I introduced, would change that. This bill provides for a fully coordinated, bundled care model that will help patients in their entire continuum of care in receiving treatment for opioid addiction through the medication-assisted treatment programs, which combine the use of medication with counseling, group therapy, and drug testing. President Trump's Commission on Combating Drug Addiction and the Opioid Crisis recognized the value of medication-assisted treatment, finding that this treatment option has proven, quote, to reduce overdose deaths, retain persons in treatment, decrease use of heroin, reduce relapse, and prevent spread of infectious diseases, end quote. For example, Jeff from North Carolina became dependent on opioids after a difficult back surgery. He initially tried to stop cold, but went into withdrawal and relapsed. Fortunately, Jeff was able to receive treatment from the Goldsboro Comprehensive Treatment Center, where he went through counseling. His progress was monitored, and monthly drug screens kept him accountable. He now says his life has changed for the better 100%. Every member of this committee, Mr. Chairman, has constituents like Jeff who have struggled with addiction but can regain their life with the right treatment. While there is no silver bullet to this crisis, we need to ensure patients and doctors have all options at their disposal to combat the opioid epidemic. So thank you, Mr. Chairman, and thank you, Mr. Neal, for introducing this bill with me, and thank you for us marking up this package, and urge my colleagues yes vote, and I yield back.
Thank you, Mr. Holding. I'll now turn to Mr. Neal for purposes of
Thank you, Mr. Chairman, and I want to thank Mr. Holding as well as Mr. Taylor from Virginia and Mr. Cartwright from Pennsylvania. as well. The Medicare Opiate Safe Treatment Act of 2018 focuses on increasing treatment disorder for Medicare and individuals suffering from opioid use disorder. Currently, Medicare covers substance use treatment when it is medically necessary and provided at Medicare-certified inpatient or outpatient treatment centers. But there are still significant gaps in access to treatment and services for some Medicare beneficiaries at risk for or suffering from opioid use disorder. Compared to other groups, individuals over 65 have the highest rate of opioid-related inpatient stays now in 13 states. This bill expands Medicare coverage to include opiate treatment programs for the purposes of delivering medication-assisted treatment, including with methadone, to Medicare beneficiaries. Medicare will pay for outpatient care through bundled payments made for holistic services, including necessary medications, counseling, and testing. This has been a surprise to me, Mr. Chairman, to discover that this sort of problem actually occurs in America. So I think with the work that Mr. Holding and I have done on this, with pretty good staff work, I think that this is a necessary example of how we have to get out in front of a fast-growing scourge among senior citizens across the country. And I hope that the legislation will be looked favorably upon with the committee.
Thank you, Mr. Neal. We'll now proceed to consideration of H.R. 5776. Without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in nature substitute, which was distributed in advance along with the green sheet explaining it. Without objection, amendment in nature substitute shall be considered as read, open for amendment at any point, and considered base text for the purpose of amendment. I'll now turn to Nick Ulecki, professional staff for the Health Subcommittee, to provide the technical description of the amendment in nature of substitute with an emphasis on the changes made since introduction. I ask that members hold their questions until after his presentation. Mr. Ulecki.
Thank you, Mr. Chairman and Ranking Member Neal. H.R. 5776, the Medicare and Opioid Safe Treatment Act, was introduced by Ranking Member Neal and Representatives Holding, Taylor, and Cartwright. In general, this legislation would take steps to expand access to medication-assisted treatment and other non-opioid alternatives. H.R. 5776 contains a number of other provisions that have been introduced previously. A provision based on H.R. 5080, introduced by Representative Holding, and H.R. 5083, introduced by Ranking Member Neal, would provide coverage of methadone along with other preventative medications through medication-assisted treatment programs paid for under bundled payments for holistic care in the Medicare program. H.R. 5778, introduced by Representative Marchant and Health Subcommittee Ranking Member Levin, would require the Secretary of the Department of Health and Human Services, or HHS, to evaluate Part B payments and update, if necessary, the outpatient prospective payment system and payments to ambulatory surgical centers to promote access to non-opioid alternative treatments. H.R. 5769, introduced by Representatives Rothfuss and Davis of Illinois, would provide funds to federally qualified health centers and rural health clinics for the certification and education of providers to dispense medications for the treatment of opioid addiction. H.R. 5725, introduced by Health Subcommittee Chairman Roscom and Representative Sanchez, would direct the Secretary of HHS to evaluate the extent to which Medicare Advantage, including special needs plans, offer medication-assisted treatment and cover non-opioid alternative treatments that are not otherwise covered under traditional Medicare as part of a supplemental benefit, and what the potential barriers are to these plans using their supplemental benefits to cover these types of services. H.R. 5790, introduced by Representatives Noem and Chu, would direct the Secretary of HHS to educate patients on the availability of psychologist services and explore, possibly through demonstration, the use of 24-hour hotlines to reduce unnecessary hospitalizations and emergent care in the Medicare program. H.R. 5722, introduced by Representatives Walorski and Chu, would require a report in consultation with hospitals and other stakeholders containing recommendations on how to improve payment and coverage related to the use of multidisciplinary, evidence-based, non-opioid treatments for acute and chronic pain management for Medicare beneficiaries. As noted on the green sheet, the Chairman's amendment would make technical corrections to the legislation. Mr. Chairman, that completes my walkthrough. I'm happy to answer any questions.
Thank you. Are there any questions about the amendment in the nature of a substitute? Does anyone wish to strike the last word? Ms. Chu, you're recognized.
Mr. Chairman, as we've seen and heard here today, there is no congressional district which has not been impacted by this crisis. And the bill before us, H.R. 5776, the Medicare and Opioid Safe Treatment, or MOST Act, contains numerous provisions that are aimed at helping Medicare beneficiaries access treatment for their addiction disorders. This bill contains two bipartisan provisions I authored with members of the committee. First, I'd like to thank my colleague, Congressmember Walorski, for working with me on language that would direct CMS to study barriers to patient access to non-drug alternatives for opioids in acute and chronic care settings. Now, not every alternative will work for every patient or in every setting. Like most medicine, this is not a one-size-fits-all solution. But when we're dealing with a crisis as enormous as this, I believe we should have every tool in the toolbox. Studies conducted by NIH have concluded that alternative treatments like acupuncture can be effective in treating conditions like chronic pain. And we know access to physical therapy also helps alleviate pain and eliminates the need for an opioid prescription. By asking CMS to examine where barriers to these alternatives exist, we can open the door to more treatment options for beneficiaries. Secondly, I'm proud that this bill includes language specific to increasing the availability of psychologists in the Medicare program. I worked on this provision with my colleague, Congressmember Noem, who's been a longtime supporter of psychologist services. This bill would direct the Center for Medicare and Medicaid Innovation to support ways for beneficiaries to familiarize themselves with coverage for psychologist services and requests a study from the General Accountability Office on the viability of mental and behavioral health services in the Medicare program. As one of only 2 psychologists in Congress, I firmly believe that expanding access to psychologist service in Medicare is one of the most important things that we could do to improve the mental health of our senior population. Because we know that those who suffer from depression or other mental health disorders are particularly vulnerable to addiction. And for those who already have taken the incredibly difficult step of seeking treatment, we need to ensure that they have full access to the range of mental health professionals who can support them on the journey to recovery. I'm also pleased that this package includes a provision introduced by Ranking Member Neal, and which I'm proud to have co-sponsored. This provision would allow Medicare beneficiaries suffering from opioid use disorders to access treatment at opioid treatment programs which provide medication-assisted treatment, or MAT. MAT is one of the most effective treatments for opioid use disorder and uses medications like methadone or buprenorphine and counseling and behavioral therapies. By allowing Medicare to bundle MAT therapies, this bill will help beneficiaries access an entire package of services from care coordination to social services. This bill is a step in the right direction, expanding treatment options for Medicare beneficiaries who need it. But I believe that we need to be doing more. We need to be investing significant federal funding in expansion of prevention, treatment, and recovery efforts. I've spoken to recovery advocates who've noted the severe lack of resources and support for those who just left treatment and are newly in recovery. Addiction is a lifetime disease, but once someone has completed treatment, maintaining recovery takes a lifetime. Often these individuals have no housing and no support system when they leave treatment, and with relapse rates so high for those suffering from opiate addiction, I believe that in order to truly combat this crisis, we need focused efforts to help people who've made it through treatment rebuild their lives and stay sober. I hope this markup significantly is the beginning of a series of actions that the committee will take on this issue. I yield back.
Gentlelady yields back. Ms. Noem, you're recognized.
Thank you, Mr. Chairman, and I want to thank you for holding this markup. It's been a huge undertaking, and I applaud you and the staff for all of your work. Today, I am proud to join my colleague, Rep. Chu, as we consider the MOST Act, which contains our bill, H.R. 5790. It's called the Medicare Nurse Hotline Act. And the information that we obtain from the testing and the studies required in this bill are going to help us chart a path forward towards full inclusion of clinical psychologists into Medicare. But it's only a first step, and I'm proud to be the House sponsor of the Medicare Mental Health Access Act, which would ensure that our seniors have full and unfettered access to clinical psychologists. Clinical psychologists are critical to the fabric of our mental health care system, and seniors deserve easy access to all kinds of medical health providers without burdensome supervision requirements. So, Mr. Chairman, while we're unfortunately not considering that bill today, I pledge to continue working with you and your staff to perfect the bill's language and pursue a CBO score so that we may consider it in the future. And with that, I yield back, Mr. Chairman.
Thank you. Gentlelady yields back. Mr. Hickens, you're recognized. Strike the last word.
Thank you, Mr. Chairman. I'm proud to join my colleagues today to advance legislation to combat opioid epidemic. Our hospitals, physicians, nurses, social workers, community clinics, and not-for-profits are working together, and we need to provide them with more tools and resources. This is a crisis of huge proportion, and our response must match it. According to the Centers for Disease Control and Prevention, 45,000 Americans died from opioid overdoses from July 2016 to July 2017. This staggering number surpasses the 38,000 Americans who died the previous year. The committee will consider my bipartisan bill with Congressman Jason Smith of Missouri. Our bill would provide hospitals and prescribers with information they need to make best possible decisions for their patients regarding opioids. The bill will impanel a group of technical experts to provide recommendations on reducing opioid use in surgical setting and best practices for pain management following surgery. Why do we need this bill? Most members of Congress are not doctors and not experts in opioid dosage best practices, but we know that new studies are increasingly showing that opioids are still overprescribed, including after surgeries. Avi and Julie Israel, local advocates in my district, have long noted how it is too common for patients to become addicted to opioid medications after surgery. Their organization, called Save the Michaels of the World, was established after their son Michael tragically died due to complications related to opioid addiction. This addiction was preventable and was due to the treatment for chronic disease, Crohn's disease. While small in scope, our bill would give providers tools to help prevent the onset of addictions in cases like Michael's. I will continue to fight for those in my community and their families and caregivers who are struggling with the addiction, help they need. Taken together, the legislation we are considering today are helpful, but we must not let up, and we must do more. I yield back.
Thank you, Ms. Wolodarski. You're recognized. Strike the last word.
Thank you, Mr. Chairman. Solving the opioid epidemic requires everyone to work together at all levels, from the federal government down to those on the front lines of this fight. Our continued focus is to make sure our communities have the resources to treat addiction and pain and will save lives. That's why I support Ranking Member Neal's legislation, the Medicare and Opioid Safe Treatment Act. This vital piece of legislation includes my bill, H.R. 5722, the Dr. Todd Graham Pain Management Improvement Act that I introduced with Congresswoman Chu. I want to thank her for her support and valuable input on this critical piece of legislation. The bill is named after my friend, Dr. Todd Graham. He was a double board-certified physician in both physical medicine and rehabilitation and pain medicine who lived and worked in my district in northern Indiana. Last year, I'm sure you recall this, he was senselessly murdered after refusing to prescribe an opioid to a patient. It was his first time seeing her as a patient, and she was insisting on a prescription. He made the hard decision to not give in to demands to prescribe an opioid when it wasn't the appropriate treatment. The patient's husband, who accompanied her to the appointment, became so angry that Dr. Graham felt the need to get out his phone and even record the conversation. If you talk to doctors across the nation, these types of heated interactions are becoming more commonplace. In this case, Dr. Graham's case, 2 hours after the couple left his office, the husband returned and shot him in the parking lot. Dr. Graham prided himself on serving his patients in a friendly and caring fashion. He treated each person individually, taking this time specific steps to treat their issues. His loss has been a heavy blow that is still reverberating throughout my district almost a year. However, Dr. Graham's legacy of compassion and enthusiasm lives on through his wife, Julie, their 2 daughters, and their son, who plan to follow in his footsteps of his father. I would like to recognize Julie Graham here today, who flew out here today to witness this bill's passage out of our committee. This epidemic knows no boundaries. Opioid abuse continues to devastate families and communities like mine. In Dr. Graham's case, addiction drove someone to murder a doctor who was trying to apply the right treatments instead of simply writing a prescription. As we continue to take steps to reduce opioid abuse, we have to do more to ensure patients have access to non-addictive pain management options that provide them with a form of care that is more holistic and less prone to addiction, especially for those with substance abuse or mental health challenges. This bill directs Health and Human Services to conduct a comprehensive review on ways to improve payment and coverage policies related to the use of multidisciplinary, evidence-based, non-opioid pain management treatments for Medicare beneficiaries with acute and chronic pain. HHS would consult with stakeholders, including frontline providers and beneficiary groups, to ensure input is provided from across the medical community. The report would do the following. It would provide an evaluation of potential legislative and administrative changes to allow better access to non-opioid treatments for pain, and an analysis of the FDA-approved medical devices, non-opioid-based drugs, and other therapies for the treatment of pain that are not currently covered by Medicare. This legislation would also direct HHS to analyze the VA and Department of Defense's clinical practice guideline for management of opioid therapy for chronic pain, to consider whether the adoption of their pain rating scale would be beneficial to Medicare patients with chronic pain, and requires HHS to develop legislative and administrative recommendations for action on treatment strategies for beneficiaries with psychiatric disorders or substance disorders, those who are at risk of suicide, or those with other comorbidities that require specialty care, appropriate case management for beneficiaries transitioning between inpatient and outpatient settings or between opioid therapy to non-opioid therapy, and outreach to educate Medicare beneficiaries and providers on alternative non-opioid therapies to manage and treat acute pain. As we continue to work toward common sense solutions to the opioid epidemic, this bipartisan bill by Ranking Member Neal will help break down barriers to non-opioid treatments and give doctors better tools to prevent addictions. I support passage of this legislation, and I yield back, Mr. Chairman.
Thank you. Mr. Dog, you recognize strike the last word.
Thank you very much, Mr. Chairman. I support this legislation because it actually does something the administration could not do on its own initiative to expand access to treatment and make a contribution to addressing this opioid epidemic. Mr. Chairman, you and several members of the committee have suggested today in response to my questions that the Obama administration could have done more to address this epidemic. I think you're correct. Indeed, this committee could have done far more to address this epidemic than wait until today to act. But the outline and the severity of this problem has become more evident by the day, and it was clearly understood when the new administration came into being. Since that time, I believe that President Trump has been mainly talk and very little action in addressing the epidemic. He's given a few speeches, he's had a tweet here and there, and he's passed a resolution, or he signed a resolution declaring an emergency that has very little effect, and he suggested that if we just threw a few more people in jail, that would help solve the problem. He has not called for robust funding, and he has not outlined a detailed plan developed by drug policy professionals. Instead, he's relied on political consultants, and I think it says more than I could say in a speech about the level of his commitment, that instead of turning to a healthcare expert, to a physician, to a scientist, to a law enforcement expert, he named as the head of his opioid effort a political advisor, Kellyanne Conway, to lead the way with no drug experience and perhaps very little insight into the extent of this problem. For months prior to that, the Office of National Drug Control Policy included among its senior staff a 24-year-old former campaign aide with little applicable experience on anything and no drug policy expertise of any kind. The President entrusted the Centers for Disease Control to the leadership of Dr. Fitzgerald, an appointee who was so ensnarled in special interest that she had to recuse herself from working on the opioid crisis and was eventually forced to resign. I believe that the administration has shown a total lack of leadership on this issue, and that appointees have done the same, ignoring the hardworking drug policy professionals that have been there trying to get the attention of both administrations on this problem and trying to propose some solutions that will actually change the lives of the individuals that are so harmed by what's been happening. We have an estimated 115 deaths every day nationally, and yet only 20% of people living with an opioid addiction are receiving treatment. That's not the kind of attention that we need. And I believe that the most important step that we can take is to address and expand access to treatment. That's why I like the provisions of this bill as they're directed to seniors. As the most effective treatment for substance abuse, coverage for medication-assisted treatment is vital to get at the heart of the problem. I recognize that this Congress did approve a 2-year budget that included some additional funding for opioids. The agreement that was reached actually provides less money than even Republicans proposed last summer, and it's a small fraction of what the experts in the field say is really required. I take note of the fact that one Trump administration official recently said that when these grants are finally announced under the provisions that we approved, that our localities need to move fast because the money will be gone in a moment. The modest provisions that we're considering today will make a modest difference. It is great that every member of the committee on both sides of the aisle care about this crisis, that we're all becoming more informed and involved in it. But most of the actions being taken here and those that have been taken in the Energy and Commerce Committee would have been better informed had we heeded Mr. Kine's suggestion that we have thorough hearings over them. I think the committee, at least on our side, not all the members were aware of even what bills could come up this week until shortly before this hearing was announced. We still don't know what the cost is. We don't know whether they're necessary or whether they could be accomplished administratively or whether they will accomplish, in some cases, more than a strong letter to the Trump administration. But given the history of that administration and what it's done and the severity of the problem, I think it's good that we're passing this bill. The others, as Mr. Kine has suggested, are benign in effect and may actually contribute something to the severe problem. But until we really get serious about providing the monies needed for treatment, we will continue to have this problem. And I yield back.
Thank you, Mr. Pasquarello. You're recognized. Strike the last word.
Thanks, Mr. Chairman. I wish to strike the last word. I want to thank you and the ranking member for hosting this critically important hearing on the opiate epidemic. I'm glad that this committee has come together in a bipartisan manner to discuss a problem that is ravaging every part of each of our districts. Some of the legislation we're debating today would make important reforms, such as the ranking member Neal's legislation, and Mr. Holding, I associate myself with his words, the MOST Act, which would flip the incentives that have traditionally steered doctors towards prescribing opiates and over-prescribing opiates, and discover the barriers that have limited their flexibility in prescribing non-opiate alternatives. We have legislation that's in another committee was passed. We worked on it for a year. That committee has passed that legislation on, it's called ALTO, Alternative Methods of Handling Opiates. I'm pleased to see language in the COACH Act that would create best practices for pain management in surgical settings, and proposals in the PROPER Act that would provide beneficiaries with information about the risks, opiate use, and the coverage that they are entitled to for non-opiate alternatives. However, I would be remiss if I did not express my disappointment that the resources in this package are woefully inadequate to accomplish lofty goals. No singular legislation is a silver bullet. It will take a multifaceted effort, more importantly, sufficient funding from this Congress to reverse the spiraling trend of the opioid epidemic. For instance, we could have considered Congressman Crowley's bill that would increase residency slots for medical students specializing in substance use disorder treatment to address our tremendous doctor shortage. This is one of the many ideas that requires funds up front, but would ultimately save more costs and lives down the line. It is my hope that this is not the last set of opioid legislation to be debated by this Congress and by this committee. And I ask for a commitment from the majority to hold future hearings and consider more robust legislation on this pressing issue. And I'd like to say, Mr. Chairman, that we need to take a look on how we addressed the HIV problem back in the 80s and early 90s. I think it is a good protocol for what we should be looking at. No one wanted to touch that issue back then. People shunned away from it. We didn't even want to discuss it in the beginning. Until we came together and until the community itself rose up affected by HIV. They put in many places, many clinics throughout the United States of America where people felt comfortable to come to, open, stigma was not there, and worked very well. And I have one question, Mr. Chairman, which Mr. Ulecki could write to me about. I would hope he would. How much cumulative authorized funding is in the entirety of the proposals being considered today? If you could get back to me for that, I'd appreciate it, Mr. Chairman. And I thank you for your indulgence.
Mr. Ulecki, would you like to answer that question, or would you like to do that in writing?
I'll get back to you in writing, sir.
Is that good enough, Mr. Pascrell? Mr. Crowley, you're recognized to strike the last word.
Thank you, Mr. Chairman. Let me thank you as well for holding this hearing today on this crisis facing America. Today's markup is a positive step forward in the fight against the national opioid epidemic. This is a tragedy that does not discriminate. It has touched all communities, regardless of race, socioeconomic status, or geography. And my district is no exception. More Bronx residents died of drug overdoses in 2016 than in any other New York City borough. Out of these 308 overdose-related deaths, 85% involved opioids generally, and 76% involved heroin or fentanyl. And in Queens, over half of the opioid-related overdoses in 2016 were related to heroin. And clearly, this is an epidemic with wide-ranging consequences. The increase in prescription opioids has led to a spike in heroin use, as heroin has become more accessible and cheap in recent years. Many of the victims of the opioid crisis are clear, the young people whose lives have been cut short. Working individuals who struggle every day to break the bonds of addiction. There is also a wider impact. There are real and devastating downstream effects of the opioid epidemic. Families left without breadwinners to support them, children left without a parent to raise them, and communities slowly hollowed out as more and more people fall victim to addiction. That means that our strategy to address this national crisis must be comprehensive, multifaceted, and it must be sustainable. And that starts with two key principles. First, all Americans must have access to treatment for substance use disorder. That means passing measures before us today, like Ranking Member Neal's bill to provide outpatient access to medication-assisted treatment. But it also means expanding Medicaid and strengthening the individual market. Our responsibility is to support all of our constituents as they work to overcome their addictions. Without access to comprehensive health care services to comprehensively address addiction, our support is only a Band-Aid approach. The second principle is that addressing the opioid epidemic requires a solid public health infrastructure. Let's remember, the opioid epidemic is not an epidemic of the last year, but rather this has been decades in the making, and so will require years to address. It will require federal investment in public health infrastructure. That starts with sustainable funding for community health centers, which are on the front lines of this crisis, treating countless overdoses while expanding their capacity to deliver treatment to those struggling with the many diseases of distress, like alcoholism and abuse of drugs and other opioids. And it means investing in our health system, workforce, training providers so they can close the treatment gap for the millions of Americans with substance use disorders that have yet to receive the care that they need. In 2016, approximately 21 million people needed substance use treatment, but less than a fifth of them received any form of that treatment. Though there are several reasons for this treatment gap, the existing and looming shortage of physicians and other health care providers only exacerbates this problem. To address this, and I appreciate the words of my colleague from New Jersey, Mr. Pascrell, in mentioning it, I have authored legislation, the Resident Physician Shortage Reduction Act, which would allow teaching hospitals to meet local and national workforce needs, including the wide range of disciplines needed to address the opioid epidemic. But to address this particular crisis facing our nation, I recently introduced the Opioid Workforce Act, which would more directly increase support for addicted treatment workforce. This legislation will provide 1,000 additional residency positions to hospitals that have or are establishing residency programs in addiction medicine, addiction psychiatry, or pain management. This bill provides a long overdue investment in our healthcare system, infrastructure, and workplace development. Without more physicians trained in treating substance use disorders, we won't be able to address the opioid epidemic. I hope my colleagues will join me in supporting this new proposal. In addition to efforts we make to address this crisis through our healthcare system, we must consider the downstream effects on communities that were already once left behind by the failed war on drugs. Many communities in my district are still recovering from the aftermath of the failed tough-on-crime tactics of the 80s and 90s. Residents have not properly dealt with their addictions because of the fear of criminal retribution, and they are more likely to use and abuse newly and more cheaply available heroin. More and more often, heroin is laced with synthetic opioids like fentanyl, which is nearly 100 times more potent and is more likely to lead to an overdose and death. While we work to address the opioid epidemic, we must not repeat our past mistakes by leaving behind our most vulnerable communities. We cannot subject them to the same ineffective drug enforcement policies of the past. Instead, we must work together on a more holistic approach that focuses on treatment rather than punishment. And Mr. Chairman, addressing this epidemic will take an investment of federal resources, multiple perspectives at the table, and persistence to get it right. One markup will not solve this epidemic. And again, I sincerely thank you for this markup today on these important bills and this legislation before us. And I yield back.
Gentleman yields back. Ms. Sanchez to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word. I'm glad we're here today to take another step towards addressing the nation's opioid epidemic. As tens of thousands of American families well know, this work is critically important, a matter of life and death in many cases. It will take a sustained effort on our part to meaningfully address the crisis, and I look forward to working with all of you going forward. The national conversation on the opioid epidemic rarely sheds light on the ways in which older adults have been impacted. It's a shocking and tragic reality that opioid use disorders are rapidly growing among Medicare beneficiaries. We know that Medicare Part D spending on opioids far outpaces enrollment. And within Medicare Part D, in 2016, 1/3 of beneficiaries received an opioid prescription. More than 500,000 enrollees received high amounts of opioids, and 90,000 beneficiaries were at serious risk of misuse or overdose. One of the most important things that we can do within our committee's jurisdiction is to ensure that Americans with Medicare coverage are able to get the opioid use disorder prevention and treatment services that they need. I'm glad to see that Ranking Member Neal's legislation to add opioid treatment programs as a Medicare-covered benefit for substance use disorders is included in this package, and I want to recognize Mr. Holding's efforts on this as well. We need to make sure that the people who need it are able to access treatment, and that's exactly what the Ranking Member's legislation does. There are many other helpful steps we can add and should take as part of our bipartisan work on this issue. I want to speak in support of a provision included in this package that I've championed with Health Subcommittee Chairman Roscom. With a growing share of the Medicare population choosing Medicare Advantage plans, it would be helpful to have the Department of Health and Human Services study the supplemental benefits offered by these plans to learn more about the extent to which they provide medication-assisted treatment and coverage of non-opioid alternative treatments. Through that process, we will be able to gather the data we need to determine best practices and encourage their adoption. A number of Medicare Advantage plans are doing cutting-edge work to address the epidemic by offering medication-assisted treatment, case management, non-pharmacologic treatment for pain, and partnering with providers to identify troubling patterns related to opioid prescriptions. It's my hope that with the study this legislation requires, we will learn more about these practices as well as any barriers Medicaid Advantage plans may face so that we can better support their efforts. I also believe that we need to do more to ensure that children and young adults, particularly those living in underserved areas or communities, are able to access behavioral health services. I'm proud to have worked with Congressman Griffith to introduce a bipartisan and bicameral Improving Access to Mental Health Services Act. Our legislation allows members of the National Health Service Corps who are behavioral and mental health professionals to practice in schools, community-based settings, and allows for home visiting in order to best meet the needs of their patients and communities. Right now, CORE members are only able to provide care at approved service sites. Approved sites can be school-based clinics, but schools without clinics are not approved sites. By giving existing CORE members further flexibility in where they are able to practice and deliver care, those living in underserved areas would have better access to needed health services. I'm heartened to see that our legislation has advanced through the Senate Help Committee, and I'm hopeful that it will be included in any final opioids package. We've lost thousands of lives to this crisis, and many more hang in the balance. I look forward to continuing this important work with all of you in the months to come, and I yield back the balance of my time.
Gentlelady yields back. Mr. Levin, strike the last word.
Thank you, Mr. Chairman. It's important that we've all joined together on this vital issue. I think all of us are asking why this nation did not learn earlier of this crisis. In Michigan, every day we lose 5 of our neighbors, our friends, in some cases families, to this epidemic. So I very much support the legislation that Mr. Neal and others have put together. But let me suggest that we need to be consistent. For example, when there are proposals to dramatically cut support for Medicaid, there is, as a result, a potentially very dangerous impact on the ability of people to access treatment. Secondly, I think also we have to ask ourselves about the proposal to change policies so that where there is a pre-existing condition, there would not be available that insurance. If we do that, we're likely going to cut off the coverage for hundreds of thousands of people who need that coverage because of their addiction. So there is such an urgency here that I think we need to, as we approach these larger issues, ACA, Medicaid, Medicare, this bill does that to some extent, and the proposals to essentially undermine the requirements for health insurance that's put forth through the private sector. I think everybody on this committee has to ask, well, we're passing this legislation today. Hopefully it will come to the floor. But subsequently, are we not taking steps that really would undermine and undercut what we're doing today? That's a real inconsistency that looms. And I hope very much with the intensity of feeling here today, as is absolutely necessary, I could never understand why tens of thousands of pills could be shipped to one place. What was going on? Who was asleep? And I think we need to wake up and wake up fully as we do that, Mr. Chairman and my colleagues, to be consistent. Don't take one step forward and then take 3 or 4 steps backwards in terms of providing the adequate resources, the adequate treatment for people who suffer from this addiction. I yield back.
Gentleman yields back. Dr. Davis, you're recognized. Strike the last word.
Thank you, Mr. Chairman. I too support H.R. 5766, the Medicare and Opiate Safe Treatment Act. This bipartisan legislation contains the Rothfuss-Davis bill with regard to health centers in Section 3 of Ranking Member Neal's, Holden, Taylor, and Cartwright's bill. It would help federally qualified health centers and rural health clinics to afford the cost of training providers to get certified to prescribe methadone, Suboxone, buprenorphine, and other forms of medications. Currently, health centers serve about 25 million people annually. The Affordable Care Act of 2010 funded community health centers for $11 billion over a 5-year period for the operation, expansion, and construction of facilities. For every $1 invested in health centers, there is a $5 return to help create jobs and serve people regardless and regarding their health care needs. Keeping the Medicaid expansion available and appropriately funding is essential to our health care system, especially for our federally qualified and rural health centers. In my district alone, there are 40 community health centers and a significant number of health center sites in the metropolitan Chicago area. Many of these health centers serve low-income and are disadvantaged populations. Health centers are required by statute to provide health care for all individuals, regardless of their ability to pay. These requirements make health centers part of the health safety net, providers that serve the uninsured and underinsured, and in areas that have the most, and I emphasize the most, epidemics of opiate. This bill is going to help provide a large number of providers with the skills that they need in order to prescribe the medication needed. I agree with all of my colleagues who've spoken and yield back the balance of my time.
Gentleman yields back. Does anyone wish to strike the last word? Are there any amendments to the amendment in the nature of a substitute? If there are no amendments, questions on the adoption of the amendment in nature of substitute, all those in favor signify by saying aye. Aye. All those opposed, no. In chair, the ayes have it. The amendment in nature of substitute is agreed to. I'll now recognize Mr. Reichert for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 5776 as amended to the House of Representatives.
Question is on favorably reporting the bill. H.R. 5776 is amended. All those in favor signify by saying aye. Aye. Those opposed, no. Being the chair, the ayes have it. The motion is agreed to, and H.R. 5776 is amended. It's ordered favorably reported to the House without objection. I ask the staff be authorized to make technical conforming changes to the bill. The members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our next order of business, H.R. 5773, the Preventing Addiction for Susceptible Seniors Act. I'll now turn to the bill's sponsor and the chairman of the Health Subcommittee, Mr. Roscom, for the purposes of an opening statement.
Thank you, Mr. Chairman. We had an interesting experience back in February of the Health Subcommittee. I wish everybody on the committee could have attended. The Health Subcommittee had a hearing. It was 2 panels, and we heard from people who were doing interesting things, very forward-leaning. What was interesting about the hearing itself was there was no hubris on the dais. There was nobody that was here saying, oh, if you'd only taken my 3 easy points on the opioid crisis, none of this would have happened. Similarly, I think the smart people who look at this crisis recognize there's really not many clean hands on this issue. There's government policies that have driven the opioid crisis, just without question. The notion of being evaluated, a health system being evaluated for how it handles pain. Pain is the 5th vital sign and so forth, created an incentive for health providers to say, hey, if you're going to evaluate me on pain, here's the remedy. I'm going to make pain go away, and I'm going to get better scores as a result. That's part of the problem. Another part of the problem is pharma. We all know, and that's going to be dealt with largely in the courts retroactively in terms of damages and misrepresentations and so forth. Healthcare community, in part, is complicit in this and not wanting to deal in some cases with underlying problems and wanting to have situations go away and writing a script rather than dealing with an underlying problem. And then we as a culture really are struggling with how it is that we navigate through pain. We don't like pain. I don't, you don't, nobody does. And I think we put a tremendous amount of pressure on healthcare providers to make pain go away. And so now we're coming to terms with that, but it's been a hard journey, but I've really appreciated that hearing in particular based on the lack of hubris and the humility on the parts of members that realize we really need to be listening. The PASS Act that we're about to mark and consider is a collection of bipartisan bills, obviously, that aim to prevent this overuse through increased program integrity and creating effective resources for prescribers and beneficiaries. I was pleased to introduce lock-in legislation with the ranking member of my subcommittee, Mr. Levin, as well as the Compass Act with Mr. Larson from Connecticut, which encourage providers to prescribing education through notice of outlier patterns, both of which are included in this package. Like other members on this committee, I've spent a considerable amount of time in my district listening to physicians, healthcare providers, police chiefs, educators, other caregivers, and I've heard a common theme: legislation that encourages the use of alternative treatments, that increase provider education and assist with detection of those who are at risk are things to be favored. The packages that we're moving today begin to address these issues, and I look forward to working with my colleagues and the medical community to address this epidemic. Mr. Chairman, thank you, and I yield back.
Thank you, Mr. Roxcomb. I'll now turn to Ms. Sewell, original co-sponsor bill for purposes of an opening statement. Ms. Sewell.
Thank you, Mr. Chairman. Today marks the beginning of this committee's work to address the opioid crisis. Long-term solutions will require our steadfast commitment long past today's markup. Congress is now approaching the issue of addiction the way we always should have, with prevention and treatment rather than criminalization. Substance abuse and addiction has robbed American families and communities of our most cherished asset, our people. Addiction is not a crime. It is a chronic disorder and must be treated like other chronic conditions with treatment and prevention. The opioid crisis has provided all of us with the hard lessons learned that addiction will eventually impact every community in our country. If we had addressed previous drug epidemics in healthcare settings rather than by jail cells and prisons, we might have been better equipped to handle this crisis that we're enduring today. But the bipartisan work that we're doing today is a step in the right direction to correct the injustices that we've tolerated that has been perpetrated against many in the addiction community. I want to thank Mr. Roskam for his leadership on our bill, the Preventing Addiction for Susceptible Seniors Act, the PASS Act. Since opioids can be an effective treatment for seniors with chronic pain, we've identified several policies to help prevent abuse without limiting access to needed medication. Our bill requires Part D plans to establish a lock-in program for at-risk seniors. It includes a bill that I introduced with Representative Renacek, which streamlines communication between CMS and Part C and Part D plans regarding programs integrity. Representative Swikert and Thompson have a provision also in this bill that streamlines the electronic prior authorization systems that are needed to identify and notify subscribers with outlier prescription patterns. Private and public stakeholders should be thanked for the work that they've done on this issue in recent years. I know that in my state of Alabama, so many have been stakeholders should be credited for reducing the efforts and the alarming rate by which many people died of opioids in my state. Considering that a lot of opioid addictions begins with a prescription for pain relief from an injury, the role of pharmaceuticals and research communities in developing effective and affordable non-opioid alternatives should also be acknowledged and encouraged. But let's be clear, collaboration with every willing stakeholder is necessary if we want to prevent substance abuse and improve outcomes. We have to be careful not to inhibit access to treatment for those who suffer from chronic pain as a result of sickle cell disease or cancer. So it is imperative that we do not that we not only protect these patients from restrictive guidelines, but also that we don't stifle innovation in development of non-opioid alternatives. Mr. Chairman, I'd like to submit for the record an article that was in the Washington Post that related to a victim by the name of Jessica, a victim who was an Alabama woman, not in my district, in Jasper, Alabama, but she was introduced to opioid by a doctor for a sports injury in high school. By the age of 17, she was crushing and snorting pills, which she received a total of 330 pills a month. She had 3 children and lost custody of all 3 at different points in her life. She started using heroin after losing custody of her youngest son, and then her brother died of a heroin overdose on the same day that she had been using drugs herself. The article also speaks to the financial stress that working class Americans recovering from addiction face every day. Jessica is working 10 hours on a night shift at Burger King currently. Given the hours that she works, it seems likely that Jessica falls into our state, my state of Alabama's Medicaid gap. Thanks to drug court and her determination, she has been clean for 18 months when the article was published. If she isn't emblematic of someone who deserves health insurance, I don't know who is. You see, my state of Alabama did not expand Medicaid, and so thankfully, she was only able to get treatment through drug court. The bills that we're considering today are a positive step towards our fight against opioid addiction, but they are only one step towards it. If we want to prevent the effects of drug abuse in our society, we have also to address its causes, from economic isolation to the lack of access to health care and opportunities. I am glad that we're here today addressing this in a bipartisan way, and I yield back the balance of my time.
Thank you, Ms. Sewell. Would you like to submit that article for the record? Without objection. We'll now proceed to consideration of H.R. 5773. Without objection, the measure will be considered as read and open for amendment at any point. This time, I offer an amendment in nature of substitute, which was distributed in advance along with the green sheet explaining it. Without objection, the amendment in nature of substitute shall be considered as read, open for amendment at any point, and considered base text for the purposes of amendment. I'll now turn to Nick Ulecki, professional staff for the Health Subcommittee, to provide the technical description of the amendment in nature of substitute with an emphasis on the changes made since introduction. I ask the members hold their questions until after his presentation. Mr. Ulecki, you're recognized.
Thank you, Mr. Chairman and Ranking Member Neal. H.R. 5773, the Preventing Addiction for Susceptible Seniors Act, was introduced by Health Subcommittee Chairman Roscom and Representatives Sewell, Knight, and Sinema. In general, the legislation makes statutory changes to prevent excessive opioid prescriptions and expand program integrity requirements surrounding the prescription of opioids by providers and issuers. H.R. 5773 contains a number of provisions that have been introduced previously. H.R. 5675, introduced by Representative Bill Rakis and Health Subcommittee Chairman Roscom and Health Subcommittee Ranking Member Levin, would make the Part D lock-in program, which was enacted under the Comprehensive Addiction and Recovery Act of 2016, mandatory for plans in Medicare. H.R. 4841, introduced by Representatives Schweikert and Thompson of California, would require a standardized electronic process for prior authorization for the prescription of opioids. H.R. 5715, introduced by Representatives Renacci and Sewell, would help facilitate communication between Medicare Advantage organizations, Part D plan sponsors, and the Centers for Medicare and Medicaid Services, or CMS, relating to substantiated instances of fraud, waste, and abuse. H.R. 5684, introduced by Representatives Kelly and Thompson of California, will add beneficiaries at risk for prescription drug abuse to the list of targeted beneficiaries to be eligible for medication therapy management under the Part D program in Medicare. H.R. 5716, introduced by Health Subcommittee Chairman Roscom and Representative Larson, would require CMS to, in consultation with stakeholders, establish a threshold based on specialty and geographic area for which a prescriber would be considered an outlier opioid prescriber. CMS would then be responsible for notifying prescribers identified as outliers of their status. As noted on the green sheet, the Chairman's amendment makes technical corrections to the legislation. Mr. Chairman, that completes my walkthrough, and I'm happy to answer any questions.
Thank you. Are there any questions about the amendment in the nature of a substitute? Does anyone wish to strike the last word? Mr. Renacci?
Thank you, Mr. Chairman. I want to start by thanking the committee for including my bipartisan Strengthening Partnerships to Prevent Opioid Abuse Act in this package. I also want to thank Congresswoman Soule for working with me on this legislation, as well as Congressman Guthrie and Peters from the Energy and Commerce Committee. The opioid epidemic is a serious crisis ravaging communities throughout our nation, including my state of Ohio, where nearly 3,500 people died from opioid overdoses in 2016. Many of these deaths were due to illicit drug use, but there were also 564 people who died from overdosing on prescription opioids. There are people who receive this medication through drug diversion and resale or through a legal prescription from the doctor that had too high a dosage. This problem is readily apparent in the Medicare Part D program. In 2016, over 500,000 Medicare beneficiaries were written prescriptions for opioids at nearly 2.5 times the recommended maximum for long-term use. Nearly 70,000 beneficiaries were written prescriptions at almost 5 times the recommended maximum use. Whether those providers' lack of training on appropriate dosages or, at worst, through negligence or fraudulent or abusive prescribing, there are hundreds of thousands of seniors who have been unnecessarily exposed to health risks and addiction. The Centers for Medicare and Medicaid Services does have an opioid misuse strategy which aims to lower opioid overprescribing, drug diversion, and fraud within the Part D program. While these are all laudable goals, CMS itself has handicapped its ability to measure its progress. CMS currently requires all health insurers offering Part D or Medicare Advantage plans to institute a compliance program to detect fraud, waste, and abuse and take corrective action against providers engaging in misconduct. However, when it encourages them to report this fraud, waste, and abuse, they find it doesn't actually require them to do so. This makes no sense when CMS has goals to eliminate these very things. How are we supposed to eliminate drug diversion if we don't know the number of fraudulent providers who are engaging in it? How are we supposed to eliminate overprescribing if we don't know what steps are being taken to end it? Furthermore, when plan sponsors do share information with CMS and ask for help in their investigations, they often find the agency to be a black box. CMS is not required to share with them the results of its own investigations and corrective actions, as well as information on misconduct and fraud schemes reported by the plan sponsors. The lack of transparency and communication significantly undermines each ability to combat fraud and abuse within the Part D program, as well as reduce overprescribing. That's why I introduced the Strengthening Partnership to Prevent Opioid Abuse Act, which will make common sense changes to encourage greater data sharing and coordination between CMS and insurers. This will help each of them to reduce overprescribing, fraud, and abuse within Medicare Part D. My bill requires Part D and Medicare Advantage plan sponsors to share information on the investigations and actions that are related to providers who prescribe dangerously high volumes of opioids. It also requires CMS to respond to plans regarding the referrals and the results of its investigation. Finally, it creates an online portal to facilitate this exchange of information so that each can find the providers who are overprescribing or committing fraud and take appropriate action to resolve these problems. When fraudulent providers are removed from the plan networks and the Medicare system and overprescribers are better educated on appropriate prescribing methods, fewer seniors will be at risk of overdose and addiction. I want to thank again the chairman and the ranking member for their hard work, and I encourage my colleagues to vote in support of this legislation. There are too many people in Ohio and across this nation who need others to intervene and address the behaviors of bad actors in the Medicare system, and I yield back.
Thank you, Mr. Renacci. Mr. Thompson, you recognized.
Thank you, Mr. Chairman, and thank you to Ranking Member Neal and all the staff for their work on these bills. You know, opioids are an issue everywhere, and my state of California is no exception. While the state's overall opioid-related death rate is generally low, some individual counties are experiencing prescribing rates and death rates that are among the worst in the country. These bills will help prevent deaths that are hurting so many families in all of our districts. I'm the co-author of 2 provisions in this bill. The first is an expansion of Medicare's medication therapy management program to include seniors at risk of opioid use disorder. The bill will give those seniors access to high-touch pharmacy counseling to teach them about drug interactions, alternative therapies, and tips for how to use their medications properly. In this program, we can facilitate greater communication between patients and providers about what's working, what's going wrong, and the small changes like adding over-the-counter drugs that patients could make to improve their outcomes. The second provision will cement standards for electronic prior authorizations of drugs in the Part D program. By creating one set of rules for these transactions, we ensure that the different systems can talk to one another, thereby avoiding inoperability failures that have plagued other health technologies and bringing coverage approval to patients much faster. We've heard some concern from doctors about increased prior authorizations generally, and the concept of insurance companies driving care decisions based on financial concerns rather than clinical concerns. In Part D, that's a direct result of the increasing cost of pharmaceuticals. As a doctor told me earlier this spring, by speeding prior authorizations, we're addressing a symptom of high drug costs, but we still have to cure the disease. This bill will help a great deal, and I appreciate everyone's effort and I would appreciate everyone's vote, and I yield back the balance of my time.
Thank you. Mr. Kelly, do you wish to strike the last word?
Thank you, Mr. Chairman. First, I want to thank you for holding this markup. The epidemic is killing 116 people every day, and this isn't just a health problem, it's an economic problem with a $55 billion a year cost in lost earnings and productivity. But I think more importantly, if you look around the room today, not just the people up here on the dais or the people sitting out in the room are separate. We're either dependents or codependents. This hits everybody at every level every day. I think the thing that maybe is a misconception on this, and I think Mr. Thompson was just hitting on it, it's not just young people that are being affected with this. It is seniors that are going through the same situation. The piece of legislation that I have with Mr. Thompson, Ms. McMorris-Rogers, and Mr. Doyle's 5684, this is something that will help at-risk seniors manage their medication and avoid the drug abuse. So the simple bill gives seniors who are at risk for prescription drug abuse access to medication therapy management. This successful program allows seniors to sit down with a pharmacist or other health professional and receive expert advice on how to manage their prescriptions. I don't know how many of you go to a pharmacy to pick up your prescriptions, but I know now at this point in my life, I pick up prescriptions from 2 or 3 different people. And one of the things they ask you when you pick up the prescription is, take a look at what comes with us. There's usually 3, 4, 5 pages, and they said, do you want us to counsel you on this? Or you can just check no, and we'll give you the prescription, you can leave. I think that's part of the problem. We don't know enough about what we don't know. Now, CMS has already identified this approach, and that it works to avoid opioid overuse and avoid dangerous drug interactions, expanding access to medication therapy management for at-risk beneficiaries will ensure that these dangerous drugs are used properly before it is too late. And I'd like to submit for the record, Mr. Chairman, 3 letters from organizations in support of protecting seniors from Opioid Abuse Act. It's the American Medical Association, Tabula Rasa, and the American Health Quality Association. And
without objection, Mr.
Okay, thank you. So I just urge the committee to support the common sense legislation. I think we're all aware of what needs to be done, and I yield back.
Thank you, Mr. Kelly. Does anyone else wish to strike the last? I'm sorry, Mr. Larson.
Thank you, Mr. Chairman, and thank you for this important markup. I want to applaud Mr. Roscom and Ms. Sewell for their work. I also would like to acknowledge Susan Brooks of Indiana, Peter Welsh of Vermont. And also, as Mr. Thompson did, want to acknowledge the staff. I think it's rather remarkable, especially when you hear a number of these terms like this is the PASS Act, and we're now doing the bill that Mr. Roscom and I have introduced is COMPASS. This takes an awful lot of work and creativity, I want people in the audience to know, but the chairman had said earlier today that when we had our hearing this morning, you're going to see a different group working together this afternoon. It's what the American people have called upon us to do, to come up with solutions. And all of these bills here today represent solutions that we're all working on. I would associate myself with the remarks of Mr. Kind And the chairman has already acknowledged, as well as the ranking member, the need for us to do a deeper dive into this scourge that plagues America. But in this specific area here of outreach to seniors, especially as it relates to outliers, this is important work that's not only being done here in our committee and that we're encouraging, but also in the private sector. I want to acknowledge the work of the Aetna and CMS and others that are making sure that in the effort to lower to order the abuse of prescriptions, especially as it relates to outliers, that we're successful at that. I want to acknowledge Governor Malloy in the state of Connecticut for his work, where in Connecticut we've seen a reduction of 22.3% over the last 4 years. That's a significant reduction, and I wanted to applaud him as well. With that, Mr. Chairman, I would also just point out that importantly, in looking at all of this legislation, we also recognize that there are exemptions that need to be provided for people in oncology and hospice to ensure that those in the need of end-of-life care and are in severe pain get the right dosage that they're needed as well. And so the thoughtfulness of these proceedings, I commend the chair and Ms. Sewell for their efforts, and I'm proud to be a sponsor of this bill and the bill in general. Thank you, and I yield back.
Thank you, Mr. Larson. Does anyone wish to strike the last word? Are there any amendments to the
amendment at the desk.
Substitute?
I have an amendment at the desk, Mr. Chairman.
Gentleman has an amendment. Mr. Roskin?
I reserve a point of order.
Point of order has been reserved. The clerk will distribute the amendment. Ask the gentleman from Texas to suspend while the clerk distributes. Mr. Doggett, you're recognized to speak on your amendment.
Thank you very much, Mr. Chairman. Repeatedly, President Trump has complained about the cost of drugs, especially with regard to Medicare. He has told us, quote, they don't bid them out. They say like $300 billion could be saved if we bid them out. We don't do it. Why? Because of the drug companies. And after his big Rose Garden speech last Friday, I've been trying to find a rose-tinted set of glasses thick enough to be able to find anything in his blueprint that would stop the very kind of prescription drug price gouging that he denounced that afternoon and has done so regularly in the past. With prescription drug prices rising at 10 times the rate of inflation, American consumers need deeds, not tweets. Even in the face of this opioid epidemic, a devastating national public health emergency, pharmaceutical companies have taken advantage of the situation in an incredible way. In early 2017, Kaleo Pharmaceuticals spiked the price of its auto-injector, Avizio, from $575 to $4,500, a 682% increase. Amphastar, the manufacturer for a generic nasal spray, spiked the price by 95% in 2014. Hospira, one of the leading manufacturers for injectable naloxone, spiked prices by 129% over a 4-year period. All of these price hikes were happening at the very same time that opioid overdose deaths were rising dramatically. Just as President Trump has promised to rein in this kind of price gouging, he's also promised to resolve the opioid epidemic, and yet none of his proposals have included a call to bring down the price of naloxone. Pharmaceutical companies continue to have unchecked power to raise the price of their drugs. In a rare public health advisory from the U.S. Surgeon General, the public is now being called upon to carry naloxone with them, but it's impossible to do that when the drugs are unaffordable. Among those who are most directly impacted by this incredible amount of price gouging that is occurring with naloxone are the police departments and the fire departments across the country that are being asked to stock it to deal with the potential for overdose deaths. One community after another has been seeking relief in this regard. Just run through a few headlines. One, how does a $575 life-saving drug jump to $4,500? Blame a perverse system. The New England Journal of Medicine, the rising price of naloxone risk efforts to stem overdose deaths. Scientific American, massive price hike for life-saving opioid overdose antidote. Narcan prices are skyrocketing, and cities are begging for help to buy it, says another. National Public Radio, first responders spending more on overdose reversal drug. ABC News Radio, health workers ration opioid overdose antidote amid price hikes. There is something we can do about this. This amendment is very direct. While I would like to see us address the broader question of negotiation to reduce prices and achieve the $300 billion savings that President Trump once urged that we do, this amendment is narrowly focused, and it simply directs the administration to negotiate the prices on naloxone so that our police departments and our fire departments are not overburdened, and so that consumers are not overburdened by those who engage in price gouging. And I would move adoption of the amendment. I think it would be a really constructive measure to help local government, to help consumers, and to deal with an issue that is central to this opioid abuse problem, and that is how do we prevent deaths from overdoses before we begin the treatment that is so desperately needed to address this crisis. So I move adoption of the amendment and urge my colleagues to join in supporting it.
Mr. Roskin, you're recognized.
Mr. Chairman, I make a point of order to the amendment because it's not germane to the amendment in the nature of the substitute. The amendment violates House Rule 16, Clause 7, because the chairman's amendment in the nature of a substitute is focused on improving existing program integrity efforts and beneficiary resources to improve medication adherence, and this amendment creates new authority for the Secretary to negotiate drug prices.
Does the gentleman offering the amendment wish to speak on the point of order?
Very briefly, Mr. Chairman. I think it goes to the heart of the integrity of our system. We've seen one report after another about the pharmaceutical lobbyists that fill this building. They have more than 2 lobbyists for every member of the House and the Senate. The work that they do with the administration has been very effective, as indicated by the President abandoning the very promises that he made on prescription price gouging. The bills that we're considering today have been narrowly structured to limit what amendments can be offered. I think that giving new authority to address this problem and help our police and fire departments and help consumers everywhere goes to the heart of this. I wish that separate legislation could be approved to be considered, but this is the one bill where offering this amendment, it could be incorporated. We could provide this relief if there were a will by the majority to do so, and I urge the chair to permit the consideration of this amendment.
Thank you. I am prepared to rule the amendment is not germane to the amendment in nature substitute. This violates House Rule 16, Clause 7, because the amendment in nature substitute is focused on improving existing program integrity efforts. The amendment creates new authority for the Secretary to negotiate drug prices, has a different fundamental purpose. The point of order is sustained. The amendment is not in order.
Mr. Chairman,
Yes,
on
sir.
that I would respectfully appeal your ruling.
Gentleman appeals ruling chair. Mr. Roskin, do you move to table the appeal?
I do.
Questions on the motion to table the appeal of the chair's ruling? All those in favor signify by saying aye. Those opposed, no.
No.
Being the chair, the ayes have it. The motion table is agreed.
Mr. Chairman, on that I would request the yeas and nays.
A roll call vote is requested. The clerk will call the roll.
Mr. Johnson? Aye. Mr. Johnson, aye. Mr. Nunes? Mr. Reichert? Mr. Reichert, aye. Mr. Roscom? Mr. Roscom, aye. Mr. Buchanan? Mr. Buchanan, aye. Mr. Smith of Nebraska? Mr. Smith, aye. Ms. Jenkins? Mr. Paulson? Mr. Paulson, aye. Mr. Marchant? Mr. Marchant, aye. Ms. Black? Ms. Black, aye. Mr. Reed? Mr. Kelly? Mr. Kelly, aye. Mr. Renacci? Mr. Renacci, aye. Ms. Nome? Ms. Nome, aye. Mr. Holding? Mr. Holding, aye. Mr. Smith of Missouri? Mr. Smith, aye. Mr. Rice? Mr. Rice, aye. Mr. Schweikert? Mr. Schweikert, aye. Ms. Walorski? Ms. Walorski, aye. Mr. Curbelo? Mr. Bishop? Mr. Bishop, aye. Mr. LaHood? Mr. LaHood, aye. Dr. Winstrup? Dr. Winstrup, aye. Mr. Neal? Mr. Neal, no. Mr. Levin? Mr. Lewis? Mr. Lewis, no. Mr. Doggett? Mr. Doggett, no. Mr. Thompson? Mr. Thompson, no. Mr. Larson? Mr. Larson, no. Mr. Blumenauer? Mr. Kind? Mr. Kind, no. Mr. Pascrell? Mr. Pascrell, no. Mr. Crowley? Dr. Davis? Dr. Davis, no. Ms. Sanchez? Ms. Sanchez, no. Mr. Higgins? Mr. Higgins, no. Ms. Sewell? Ms. Sewell, no. Ms. Del Bene? Ms. Del Bene, no. Ms. Chu? Mr. Nunez? Mr. Nunez, aye. Ms. Jenkins? Ms. Jenkins, aye. Mr. Reed? Mr. Curbelo? Mr. Levin? Mr. Blumenauer? Mr. Crowley? Ms. Chu? Chairman Brady? Chairman Brady, aye. The gentleman is not recorded.
No.
Mr. Levin, no. Mr. Chairman,
The clerk will report the vote.
22 yeas, 13 nays.
There being 22 ayes and 13 noes, motion table is agreed to. Are there additional amendments to the amendment in the nature of a substitute? If there are none, questions on the adoption amendment in nature of substitute, all those in favor signify by saying aye. Aye. Those opposed, no. Any chair, the ayes have it, and the amendment in nature of substitute is agreed to. I'll now recognize Mr. Johnson.
Thank you.
I don't think he does have it.
Mr. Chairman, I move the committee favorably report H.R. 5773 as amended to the House of Representatives.
Question is on favorably reporting the bill, H.R. 5773's amendment. All those in favor signify by saying aye.
Aye.
Those opposed, no. The opinion shared, the ayes have it. The motion is agreed to, and H.R. 5773 is amended. So we're favorably reported to the House. Without objection, I ask the staff be authorized to make technical informing changes to the bill. Members have 2 additional days. File with the committee clerk supplemental, additional dissenting or minority views. Members, we have 3 bills left. Votes we expect around 5:30. I think with a little diligence and work, we can conclude this work before the votes. If not, we will recess and come back. Our next order of business, H.R. 5676, to stop excessive narcotics in our Retirement Communities Protection Act. This bill would create parity between private plans and fee-for-service and the ability to suspend payments to providers that have shown credible allegations of fraud. This is an important step to reduce fraud and abuse in the Medicare system and to prevent improper payments from going out, as today private plans are unable to take immediate action against providers that are clearly doing something wrong. I'll now turn to Mr. Blumenauer. I'll now turn to Mr. Blumenauer, who survived the Rules Committee, original co-sponsor of the bill for purposes of an opening statement.
Thank you very much, Mr. Chairman. As you know, we've got an antiquated law that prevents life-saving medical care for patients in recovering for substance abuse disorders. Originally designed to protect the privacy of individuals in addiction treatment, this decades-old barrier now creates an impediment to delivery of integrated care. We're working now with friends in the Commerce Committee to deal with the Drug Abuse Prevention, Treatment, and Rehabilitation Act of 1872, which currently governs how doctors and healthcare professionals share alcohol or substance abuse disorder treatment records. Under this law, which predates HIPAA, patient medical records from addiction treatment facilities are segregated from the patient's medical record. This creates a life-threatening firewall that prevents medical doctors from knowing the full treatment history of the patient. And we're working to change the 42 CF Part 2, or simply Part 2, to be able to supersede this restrictive firewall. Our nation's healthcare delivery system has changed pretty dramatically over the course of the last 40 years, and I just wanted to put on the radar screen something that we are working on with the Commerce Committee to try and make to try and correct this situation. Right now, I know I need to talk about 5676, but I wanted to put that issue before you because it's a little contentious right now with our friends with the Commerce Committee, and I hope all of us can focus on the ability to make a change here. Right now, we are looking under 5676 to expand the oversight of opioid prescribing and payment for the Senior Act. We are hopeful that we're going to be able to suspend payments of Medicare prescription drug plans and Medicare Advantage plans pending investigations of credible allegations of fraud by pharmacies. This is a very simple provision. I think it's broadly accepted. It's going to make a difference to bring into compliance with the Medicare Advantage plans to make sure that we can put a stop to fraud by the pharmacies. It's a minimum I think we can do to help protect our seniors. I would hope that there is broad support on the committee to move it forward, and I will get out of your way and thank you for your consideration.
Let's move forward right now. Thank you, Mr. Blumenauer. We'll now proceed to consideration of H.R. 5676. Excuse me. Without objection, the measure will be considered as read and open for amendment at any point. This time I offer an amendment in H substitute, which was distributed in advance along with the green sheet explaining it. Without objection, the amendment in nature substitute shall be considered as read, open for amendment at any point, considered base text for purpose of amendment. I'll now turn to Nick Ulecki, professional staff for the Health Subcommittee, to provide the technical description of the amendment nature of a substitute with an emphasis on the changes made since introduction. I ask that members hold their questions until after his presentation. Mr. Ulecki, you're recognized.
Thank you, Mr. Chairman and Ranking Member Neal. H.R. 5676, the Stop Excessive Narcotics in Our Retirement Act, was introduced by Representatives MacArthur, Blumenauer, Tonko, Schweikert, Collins of New York, and Representative Custer. The legislation would extend to Medicare Advantage and Part D plans the authority to suspend payments in cases of credible allegations of fraud. As noted on the green sheet, the Chairman's amendment makes technical corrections to the legislation's short title. Mr. Chairman, that completes my walkthrough. I'm happy to answer any questions.
Thank you. Are there any questions about the amendment in the nature of a substitute? Does anyone wish to strike the last word? Are there any amendments to the amendment in the nature of a substitute? Oh, excuse me, Mr. Schweikert. You're recognized to strike the last word.
Thank you, Mr. Chairman, though it is not on the amendment. Thank you, Mr. Chairman. I was just actually going to, because I know for a couple folks we're running through lots of different ideas and concepts, but one of the mechanisms here, it's sort of important to understand, for Medicare, this sort of, I hate to almost call it a crawlback type provision, but already exists in Medicare Part A, Part B. Now you're basically sort of putting those mechanisms now into Part D. At least the mechanism has been tested. It's been stressed. It's well known. I know every time there's a change, you often end up with certain concerns of those who are who are providers or the provider networks. But we have a long history of this, so this isn't particularly revolutionary, and it's a way to basically find the bad actors and remove them from the system. And with that, yield back.
Does anyone else wish to strike the last word? Are there any amendments to the amendment in the nature of a substitute? If there are no amendments, questions on the adopted amendment in nature substitute. All those in favor signify by saying aye. Aye. Those opposed, no. Opinion chair, the ayes have it. The amendment in nature substitute is agreed to. Mr. Roscom, I'll now recognize him for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 5676 as amended to the House of Representatives.
The question is on favorably reporting the bill H.R. 5676 as amended. All those in favor signify by saying aye. Aye. Those opposed, no. Opinion chair, the ayes have it. The motion is agreed to, and H.R. 5676 is amended. The order favorably reported to the House. Without objection, I ask the staff be authorized to make technical conforming change to the bill. The members have 2 additional days to file with the committee clerk supplemental, additional dissenting, or minority views. Our next order of business, H.R. 5723, the Expanding Oversight of Opioid Prescribing and Payments Act. This bill will require the Department of Health and Human Services to report to Congress on how payments work for pain treatment in Medicare and possible incentives for the use of both opioids and non-opioid treatments under the program. This information will allow Congress and the administration to create better programs to combat this crisis in the future by arming providers with more education on what can be done currently and what changes may be required to provide better pain treatment. I'll now turn to Ms. Delbeni, original co-sponsor of the bill, for purposes of an opening statement.
Thank you, Mr. Chairman. The Expanding Oversight of Opioid Prescribing Act will provide an important step in determining how CMS payment policies are fanning the flames of the opioid epidemic by limiting patient access to non-opioid alternatives. As cited in the administration's Commission on Combating Drug Addiction, Medicare policies actually discourage hospitals and physicians from adopting non-opioid pain management therapies. I remind you of a statistic that I brought up earlier. Over 80% of low-risk surgery patients are prescribed opioids to treat their pain, even though for many of them, alternatives are already available. Our bill directs MedPAC to further analyze this phenomenon and provide policy recommendations that would realign payment incentives to provide greater access to alternatives to opioids for pain management. I thank the committee for considering this bill today, but I must point out that this does not mean that our work is over. It's my hope that this bill advances to become law and that MedPAC provides the answers we need so the Ways and Means Committee and the whole Congress can take further action to reduce the number of opioid prescriptions and halt the opioid epidemic. Thank you, and I yield back.
Gentlelady yields back. Will now proceed to consideration of H.R. 5723. Without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in nature substitute, which was distributed in advance along with a green sheet explaining it. Without objection, amendment in nature substitute shall be considered as read and open for amendment at any point, considered base text for purpose of amendment. I'll now turn to Nick Ulecki, professional staff for the Health Subcommittee, to provide the technical description of the amendment in nature of a substitute, with an emphasis on the changes made since introduction. I ask that members hold their questions until after his presentation. Mr. Ulecki.
Thank you, Mr. Chairman and Ranking Member Neal. H.R. 5723, the Expanding Oversight of Opioid Prescribing and Payment Act of 2018, was introduced by Representatives Tenney, Delbene, and McKinley. The legislation requires the Medicare Payment Advisory Commission to send a report to Congress regarding pain treatment methods in Medicare and current incentives that providers have in delivering care with both opioid and non-opioid care options. As noted on the green sheet, the Chairman's amendment makes technical corrections to the legislation. Mr. Chairman, that completes my walkthrough, and I'm happy to answer any questions.
Thank you. Are there any questions about the amendment in the nature of a substitute? Does anyone wish to strike the last word? Are there any amendments to the amendment in the nature of a substitute? If there are no amendments, questions on the adoption amendment in the nature of substitute, all those in favor signify by saying aye. Aye. Those opposed, no. Being chair, the ayes have it. The amendment in the nature of substitute is agreed to. I'll now recognize Mr. Smith.
Mr. Chairman,
of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 5723 as amended to the House of Representatives.
The question is on favorably reporting Bill H.R. 5723 as amended. All those in favor signify by saying aye. Aye. Those opposed, no. Opinion of chair, the ayes have it. The motion is agreed to, and H.R. 5723 is amended. It's ordered favorably reported to the House, and without objection, I ask the staff be authorized to make technical conforming changes to the bill, and that members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our next order of business, H.R. 5788, the Securing the International Mail Against Opioids Act of 2018. Now turn the sponsor of the bill, Mr. Bishop, to give an opening statement.
Thank you, Mr. Chairman, for holding this important markup today and addressing legislation that is regarding the raging opioid epidemic in our country. Yesterday, I introduced H.R. 5788, the Securing the International Mail Against Opioids Act of 2018, which is being considered as part of today's markup. I want to thank Representative Pascrell for his co-sponsorship, and also former Representatives T-Berry for his sponsorship of the original bill, along with Representative Faso, who has also been very active in supporting this bill. As drafted, I think this legislation is a good first step in the right direction, but I also look forward to working with my colleagues to further strengthen this bill. Bottom line, we've got to stop the flow of dangerous drugs, including synthetic opioids coming from other countries into our country. I'm committed to working with all my colleagues, both in the House and the Senate, to ensure that we get this done the right way. For years, the opioid epidemic has ravaged our country and led to many tragic deaths in our community. My home state of Michigan is no different than any other. I've been all over my district meeting with law enforcement, doing listening sessions, town hall meetings, whatever I can, meeting with law enforcement, emergency response personnel, educators, medical professionals, parents, friends, and victims of this horrific epidemic. According to the Michigan Department of Health and Human Services from 1999 to 2016, the rate of opioid-related overdose deaths increased more than 17 times. And sadly, there are critical gaps in the international mail system that drug traffickers are taking advantage of. For example, current law does not require the U.S. Postal Service to transmit advanced electronic data to U.S. Customs and Border Patrol on international mail shipments. Yet, if you talk to Customs and Border Patrol, this is exactly the data they need to target and intercept harmful packages before they can reach their intended destinations.
So to address this critical gap, H.R. 5788 would require the United States Postal Service to do just that, to obtain advanced electronic data on inbound shipments and transmit that data to U.S. Customs and Border Protection. This legislation also contains oversight provisions to ensure that the Postal Service and CBP are held accountable to Congress for meeting the new mandates. For example, H.R. 5788 would require USPS and CBP to develop a joint strategic plan within 60 days that contains specific performance measures and benchmarks. This includes mandatory congressional oversight to ensure compliance through a reporting process to Congress every 6 months. Clearly, I think we've identified an open and glaring gap in the Postal Service, which is being exploited to the substantial detriment of our citizens. We know where it is, we know why it is. As the public policymakers that we are, it is therefore our duty to adopt a solution that solves the problem. While this bill is a good starting point, I look forward to working with my colleagues to get the policy right. I know that Senator Portman on the Senate side is also putting his heart and soul into this solution and working very hard. This is too important to get wrong. I look forward to continuing the work. Thank you, Mr. Chairman, for holding this hearing today, and I yield back the balance of my time.
Thank you, Mr. Bishop. Now turn to Mr. Pascarell. Purposes an opening statement.
Thank you, Mr. Chairman. I'm pleased that today we're considering legislation that follows up on the subcommittee hearing we held in late April. I want to thank the gentleman from Michigan, Mr. Bishop, for the work and the time he's put into this. The hearing highlighted the challenges we face in stopping opiates from coming into the United States of America. Despite current efforts of the U.S. Postal Service, U.S. Customs and Border Protection, the opiate epidemic continues to devastate our communities. Every day in the United States, 115 Americans, you've heard it a few times today, you're going to hear it again, they lose their lives to opiates. In 2016, my home state of New Jersey alone experienced 2,056 deaths. And the State Attorney General's office predicts that the number this year is going to surpass 3,000. One of the key ways that synthetic opiates make their way into this country is through the mail. And according to the Drug Enforcement Agency, China is the primary source of the fentanyl that enters the United States of America. Fentanyl is often sold online, is shipped to the United States in small quantities, making it difficult to detect. I visited the mail facility in Secaucus last week, which is one of the largest in the country. New Jersey I saw firsthand how they are screening for drugs in the mail. The USPS, the CPB, and the FDA are working hard up there and across our nation, but they could use more resources and support. The Postal Service receives an incredible and overwhelming volume of mail, handling an estimated 275 million international packages in 2016. There are clear strategies that we can employ to target risky shipments, including collecting advanced electronic data, or AED, on packages that enter the United States. Private carriers have been required to collect this information since 2002, but the Postal Service has been exempt. The information contained in AED typically includes the name and address of the shipper and the recipient, as well as the contents of the package. The CBP uses this information to identify packages that may pose a risk and place a hold on the shipment. I saw that entire operation with dogs, with electronic equipment. It's a heck of a job to go through a heck of a lot of mail. This data helps CBP identify and stop shipments of synthetic opiates coming from China and other countries around the world. Many times it is shipped in small quantities to befuddle those who are looking for it. In 2017, Customs and Border Patrol seized more than 1,100 pounds of fentanyl. This rate doubled over the year before. To address the lack of AED on mail coming into the U.S. Postal Service, I'm proud to sponsor the Synthetics Trafficking and Overdose Prevention, or the STOP Act. with my friend Congressman Pat Tiberi and Ranking Member Neal, and now the Congressman from Michigan, Mr. Bishop. This bill would require Postal Service to transmit advanced electronic data to Customs and Border Patrol on international shipments. As the testimony provided at our subcommittee hearing last month demonstrated, the Postal Service, the CBP, and Department of State have raised concern with the STOP Act as it was originally drafted. As a result, the committee has been working on a bipartisan, bicameral basis to achieve a consensus that would respond to these concerns, maintain a robust framework for AED collection, and gain broad support in the Congress. As part of that effort, yesterday I introduced the Securing the International Mail Against Opiates Act. This bill will provide clear timelines for the Postal Service to collect AED information, establish rigorous congressional oversight mechanisms, establish independent reviews of the Postal Service effectiveness of the Government Accountability Office, and provide incentives for foreign posts to provide AED to the Postal Service. I believe this legislation is a strong starting point as we move forward with passing legislation on this issue. It is not a panacea, but will move us to a step forward. There is more to be done, and I continue working with my colleagues and stakeholders as we try to perfect this legislation. The opiate epidemic is a devastating problem affecting our communities, and it deserves serious policies in response. I am committed to finding a strong yet viable approach to ensure that the U.S. government has an effective strategy in place to keep opiates from entering this country illegally. And Mr. Chairman, before I conclude, let me say this. Since being a teacher many moons ago, I've kept the same policy all the time: zero tolerance, but more importantly, no market, no sale. We need to do more work in the issue of preventing, stopping people in going down this path. We do not. We'll never have enough money if we continue just to throw money at the situation and expect that people, God bless you, are changing their whole cultural venue. They're not. And we need to take a look at the marketplace.
Thank you, Mr. Pascal. Thank you for your work on this important issue, too. We'll now proceed to consideration of H.R. 5788 without objection. Measure will be considered as read and open for amendment at any point. This time I offer an amendment in H substitute, which was distributed in advance, along with the green sheet explaining it. Without objection, amendment in H substitute shall be considered as read, open for amendment at any point, and considered base text for purpose of amendment. I'll now turn to Angela Eller, Chief Trade Counsel and Staff Director for the Trade Subcommittee, to provide the technical description of the amendment in H substitute with an emphasis on the changes made since introduction. I ask that members hold their questions until after her presentation. Ms. Eller, you're recognized.
Thank you, Mr. Chairman. Mr. Neal. H.R. 5788 requires the U.S. Postal Service to transmit advanced electronic data, AED, to Customs and Border Protection on merchandise arriving to the United States through the international mail, and mandates that agencies meet specific and detailed requirements, including that USPS transmit AED on at least 70% of international mail shipments by December 31st, 2018, and 95% by December 31st, 2022. This section allows a waiver of the mandate in only very limited circumstances specified in the bill. The section further requires USPS to transmit AED to CBP for targeting comparable to the requirements placed on private carriers. The section also authorizes the agencies to take appropriate remedial measures necessary to ensure compliance with the requirements of the Act, consistent with international obligations, up to and including refusal of shipments for which the information is not furnished or required. The section also establishes vigorous oversight mechanisms to assure that the agencies are accountable to Congress through a joint strategic plan detailing specific performance measures, as well as requirements to report to and consult with Congress every 180 days on the progress made, and annual reporting requirements as well, including an assessment of the quality of the data. In addition, the legislation requires GAO to report to Congress on the agency's progress in achieving the legislative mandates. The legislation establishes a new $1 fee on inbound express mail service items for customs processing associated with the new requirements, and also contains provisions relating to identifying and developing technology and capacity building. Thank you.
Thank you. Are there any questions about the amendment in the nature of a substitute? Mr. Renace, you're recognized.
The last word.
So hold on a minute, Mr. Renace. If there are no questions about the technical amendment, I recognize Mr. Renace to strike the last word. Thanks.
Thank you, Mr. Chairman. Ohio's been ground zero for opioid epidemic, forcing too many families to learn that their loved ones have died from an overdose. My home state, more than 2,000 Ohioans overdosed due to fentanyl or a related drug in 2016. In Congress, I've been committed to working with local and state leaders, along with input from former addicts from my district, to pinpoint the problems that have led to this current epidemic. Just this week, an article in the Ashtabula Star-Beacon in my state highlighted that most fentanyl coming into Ashtabula County is coming through the mail. Under current law, it is just too easy for an individual to use the U.S. Postal Service to ship in these deadly drugs. It's important that Congress address this issue, and I am proud to have supported bipartisan legislation championed by Senator Portman that will require the United States Postal Service to transmit advanced electronic data to the Customs and Border Patrol. While I support the legislation before us today as a good step in the right direction to tackle this problem, it is my hope that we proactively work with our Senate colleagues to ensure legislation is signed into law for the benefit of our constituents. It is also important that we work together for the betterment of our constituents and prevent the shipment of these drugs into the United States. I want to thank my friends, Mr. Bishop and Mr. Pasquarel, for the work on this issue. I also want to commend Mr. Pasquarel for speaking for almost 5 minutes without taking a breath. That was impressive. I appreciate that. And that shows your passion. And I yield back the balance of my time.
Thank you. Does anyone else wish to strike the last word? Are there any amendments to the amendment in the nature of a substitute? If there are no amendments, questions on the adoption amendment in the nature of substitute? All those in favor signify by saying aye. 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 Those opposed, no. Opinion of the chair, the ayes have it. The amendment in the nature of substitute is agreed to. I'll now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move the committee favorably report H.R. 5788 as amended to the House of Representatives.
The question is on favorably reporting the bill H.R. 5788 as amended. All those in favor signify by saying aye. Aye. Those opposed, no. Being chair, the ayes have it. The motion is agreed to, and H.R. 5788 is amended. It's ordered favorably reported to the House. Without objection, ask the staff be authorized to make technical conforming changes to the bill. The members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. There being no further business before the committee stands adjourned.